Hello everyone. السلام عليكم. السلام عليكم.
السلام عليكم. عليكم السلام. اهلا دكتور.
عليكم السلام.
الصوت واضح دلوقتي؟ Is it clear؟
الصوت واضح دكتور اسلام.
بس اظن في زي صدى صوت ايكوز كده في الصوت جامد قوي. ده عندنا بس ولا
دلوقتي احسن؟
يعني الايكو موجود برضه، بس لو انا صوتي واضح خلاص ممكن ابدا في اي وقت.
اعتقد الصوت من عندي في جهازين بس.
طب احنا ready to go؟
الان
دكتور سلمان.
دكتور اسلام.
زي حضرتك العباد. دكتور محمد سلمان، حضرتك ممكن تقول لي منين نقدر ابدا المحاضره؟ ابداها على طول ان شاء الله.
دكتور اسلام لو سمحت بس نوقف
انا سيجنال النت عندي كويسه جدا، بس ما اعرفش ليه الصوت بيروح وبيجي. فحضرتك سامعني كويس؟
احنا كل مره بنعمل كده. دكتور اسلام.
انا مع حضرتك، انا سامعك كويس جدا دلوقتي.
سامعني كويس؟
جدا.
بس لو سمحت توقف الشير سلايد عشان we will start this introduction and then you can share your screen.
حاضر. عملت بوز للشات.
السلام عليكم.
عليكم.
صوت واضح الان دكتور اسلام تسمعني؟
واضح جدا. دكتور سلمان، حضرتك بتتكلم ولا حضرتك ميوتد؟ دكتور سلمان. حضرتك مش بتتكلم صح؟ عشان مش سامع اي صوت الحقيقه. مش حضرتك مش بتتكلم صح؟
لو فريش محدش النص.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Welcome everybody. It's our pleasure to welcome you all in our new activity, and because of the situation of the COVID, still we are providing all our activities on virtual, and we hope that the situation will improve soon when we can welcome all in Bahrain, in a beautiful city of Manometer. And we hope this will be coming soon with all care taken to the all patient and the vaccination process, which will be, hope it will be effective to improve the situation. Our workshop today will be about the basic intensive care workshop, and we will talk in this volume about the basic hemodynamic stability, measure and control. I would like first to introduce what is the intensive care. Intensive care is part from the medical specialty that supports the critically ill patient whose lives are in immediate danger. Like when any vital organs such as heart, liver, lungs, kidney, or even the nervous system are affected. About 5 million adults worldwide are admitted to intensive care per year. And we thanks to the all dedicated team of medical professionals who's working in ICU. Most and the majority of the ICU patients survive. Every time our life is in danger, an intensive care team take care of us, and they take over the function of defective and damaged organ. The ICU is one of the most critically functioning operational environment in a hospital. The patients who have planned admission following surgery or unexpected admission after an accident, or be admitted because of sudden and critically deterioration to their health. The ICU team are multidisciplinary team, and they are made of highly skilled intensive care nurses, doctors, specialized trained in providing critical care. I will move quickly on the history. The 1854, where the Florence Nightingale created a separate area. They start creating the triage near the nursing station, and this is for critically injured British soldiers. In 1927, Dr. Walter Dante from Johns Hopkins Hospital arranged for a special area recovery room for increased monitoring of his post-operative neurological patient. In 1950, an anesthesiologist Peter Sever established the concept of advanced life support and keeping patients sedated and ventilated in an intensive care environment. And then during the polio epidemic in 1953, they established the first intensive care unit in Copenhagen. And today, I think with in 2020, with the COVID infection and all these things, I think the need will be changed and the critical care unit is become more demanding. I will not take too much time. I would like to welcome our first speaker, Dr. Shaima Said. Dr. Shaima is a senior cardiologist. She's working in Shifa Jazeera Medical Center in Bahrain, and she's one of famous. Okay. Yeah, sorry. I think there will be a change between Dr. Islam and Dr. Shaima. So we'll start with Dr. Islam. Dr. Islam is an assistant lecturer, and he's working in Ain Shams University. And Dr. Shaima will introduce Dr. Islam. Dr. Shaima, the floor is yours.
Good evening, all. Inshallah, it will be a good and very successful workshop for all. I'll introduce my colleague, Dr. Islam Muhammad Shahata, Assistant Lecturer, Clinical Department of Anesthesia, Ain Shams University, Faculty of Medicine, Cairo, Egypt. He will talk about the modes of mechanical ventilation. The floor is yours, Dr. Islam. Welcome.
Thank you, Dr. Simon. I have no conflict of interest, so I think I can start right now. Modes of mechanical ventilation. The aim of this lecture is to understand the basics. If you Google the title modes of mechanical ventilation, you will find more than 10 or 20 videos about the modes of mechanical ventilation. So we will be a little bit different. We will discuss the lecture in form of a story. The story of mechanical ventilation had been started during the polio pandemic, when the people were dying from the respiratory failure. So they started to think about making something simulating the spontaneous ventilation called iron lung. They put the patient here, turn on a vacuum, creating a negative pressure around the chest, so the chest will expand. Turn off the vacuum, it will collapse again. But it wasn't functioning well. So they the transition from the negative pressure to the positive pressure ventilation, which nowadays is fundamental or trend. They thought how to push the air inside the airway. Instead of negative pressure ventilation, it became positive pressure ventilation, pushing the air through the airway. So they create the ventilator to push the air through the airway from the natural airway. So what's called positive pressure ventilation, and the positive pressure is the cause of all complications of the ventilation, as we will see. There are two types of mechanical ventilation. When they applying the oxygen or the gases, they apply it through endotracheal tube, so it's called invasive ventilation, or applying through a mask applied on the face, and it will be called non-invasive ventilation. We will start with invasive modes of mechanical ventilation. Attention, the next slide or the comment slide will be a little bit congested, so please focus. To understand any mode of ventilation, you should know the abbreviation, what every letter refers to. MEV in any mode means mandatory ventilation or mandatory ventilation. What does it mean, mandatory ventilation? That you will set respiratory rate. So when you set a respiratory rate, it's a mandatory ventilation. Mandatory ventilation means that you put a respiratory rate this respiratory rate will create a breathing circle. If you, for example, put respiratory rate of 12 per minute, so 60 over 12 will be 5. So every 5 seconds, the ventilator will give a breath like that. It's mandatory. So the patient will receive a breath every 5 seconds, regardless the patient awake, regardless the patient sedated, regardless paralyzed. Even if the patient is dead, the ventilator will give a mandatory breath every 5 seconds if your respiratory rate is 12. So it's, as we can see, every 5 seconds it will give a breath. So it's intermittent ventilation, not continuous. Why it's intermittent? Because the natural breathing is intermittent. Here you inhale or you get some air in, then you get the air out, then there is like automatic pause. I am speaking in the pause. So if there is no pause, I can't speak. So the natural breathing, there is inhalation, there is exhalation, and there is a pause. So it's intermittent, simulating the physiology of breathing. But the problem, if we can see here, the ventilator will get a breath here. This breath happened in the inhalation or in the inspiratory phase of the patient. That's good. But in this breath, it happened in the expiratory phase of the patient. So we can imagine two forces against each other. The patient tries to get air out, and the ventilator gives the air in. What will happen? It will give you a ventilator alarm because of the increase of the peak airway pressure. Two forces, air out, air in the same time. So this will hurt the patient. What should we do? We will do what's called synchronization. We will synchronize between the ventilator and between the patient. So we can give every breath in the inspiratory phase of the patient. So that's called synchronized intermittent mandatory ventilation. I hope it's clear. This is our mode, synchronized intermittent mandatory ventilation. The question here is how they make it synchronized. How they synchronize between the ventilator and between the patient. This necessitates that we look at the ventilator from inside. This is the ventilator, push the air, oxygen, gases during an inspiratory limb. You know the breathing circuit has two limbs. Inspiratory, air going to the patient, then expiratory going out from the patient. As you can see, there is a continuous flow in the circuit. When the patient tries to get air in spontaneously, spontaneous inspiration, he will get some flow in. So the flow out from him will be less than the flow in, or it will create what's called the negative pressure. We said that in the first slide, spontaneous ventilation or spontaneous breathing is negative pressure, not positive pressure. So they put two sensors in this circuit. Sensor called the pressure sensor. It will detect any negative pressure in the circuit. Any negative pressure in the circuit means that the patient tries to get air in. So it's an inspiratory phase. Please, ventilator, give the breath. If the flow of the patient, if the flow in the circuit is less than the flow in, is less than the flow out, so the patient takes some flow of the oxygen. So he is in the inspiratory phase. Please, ventilator, give the breath. And they call that trigger. So we have two types of trigger. The patient will trigger the ventilator to give a breath. How? By creating negative pressure in the circuit. As we can see, this is the line of the pressure. Anything down is negative, anything up is positive. This negative is the breathing. The called patient trigger, called spontaneous breathing, called the patient trial. The patient trial to get some air in, then the ventilator will give him the full ventilatory support. The other trigger called the flow trigger. If there is some flow missed from the circuit, if there is a negative flow, so it's a sign that the patient tries to get air in, please ventilator give him a breath. So if the patient has no trigger, the patient can't get any air, either negative pressure or either some flow, the ventilator will give him no. Why? Will not give him a breath? No, because we said it's called mandatory ventilation. There is what's called time trigger. any mandatory ventilation has time trigger. What's the time trigger? Every breath cycle, it will give a breath. If you put respiratory rate of 10 per minute, so every 6 seconds, the ventilator will give a breath. That's called time trigger. We can see here, there is no negative deflection like that. But the ventilator gives the breath because of what? Because of the time trigger. Any mandatory ventilation, any mandatory mode of ventilation has time trigger. Every breathing cycle you, the operator, set, the ventilator will give a breath. So that this is the time trigger, and this, as we can see, we can differentiate between two graphs. If the patient trigger the ventilator, it will give him a breath. If there is no trigger, the mandatory ventilation will give him a breath, because you know the patient is critically ill. You can't let the patient to manage his breathing while he is critically ill. But the problem in the SIMV mode is what will happen between the breathing cycle. You said he will give the ventilator will hold the patient here. What about the in between? If the patient tries to get some air in between, the SIMV can't help him. This is important. So they started to create another mode. This mode called what? Assisted control mode. From the name, assisted control. So there is a control, there is a time trigger, there is a mandatory mode, yes. But there is assist. Assist what? Assist every spontaneous breathing of the patient. So we can see here, if you put breathing cycles or respiratory rate of 12, the AC mode will give a mechanical ventilation or mechanical breath here and here. In between, if the patient tries, we said in a negative deflection, if the patient tries to get air, the AC mode will give him a full ventilatory support. If the patient tries to get some air in, the AC mode will assist every single breath. This is the big difference between assisted control and SIMV. Again, this is the assist control. The ventilator gives mechanical breath here and here. In between, the patient tries to get some air in, it will give him a full ventilator support. As you can see, this square like that. In the SIMV, no. This is the mechanical ventilation, and this is the mechanical ventilation. In between, this is patient spontaneous trial, no support. And therefore, we can say the difference between SIMV and assist control. SIMV can give your patient partial support. He will give him mechanical breath, but in between, he will not support your patient. So it's good for weaning when the patient is good. It can depend on himself or in herself on his spontaneous breathing. You can put the SIMV. But when you initiate the mechanical ventilation, your patient is critically ill, has respiratory failure or even cardiac failure, and you want to give him some time or buy the time for your patient, you can initiate with the assisted control, because it will give a full ventilatory support for the patient. Every single breath, he will help your patient. But there is a disadvantage, yes. If you support every single breath of your patient and the patient rate maybe 25, 30, you will cause what's called hyperventilation. The hyperventilation will wash CO2 and causes respiratory alkalosis. Alkalosis is harmful for your patient. So we have a problem. What the problem? We need SIMV with some modification so we can use it instead of assisted control to avoid the hyperventilation. I said some support, and this is the name of the new mode. SIMV plus PSV, pressure support ventilation. From its name, it's a pressure to support spontaneous ventilation. This is SIMV, mechanical breath. In between, the patient tries to get air, no help. When you provide SIMV pressure support, there is a help. So you get the same support from between the mechanical and between the spontaneous. But this is not a mechanical breath. What should I mean? In this SIMV, there is some support. SIMV pressure support. There is a support, but it's just supported by pressure. You can turn the knob to 10, 12, 15 millimeter mercury. but you do not give him mechanical breath. Mechanical breath means tidal volume, means set pressure, means respiratory rate. So the SIMV pressure support has the advantage of SIMV plus supporting the spontaneous breathing. The pressure supported ventilation, why we should support the spontaneous ventilation of any patient connected to the mechanical ventilation? Because the difference between me and the patient on mechanical ventilation, that the patient on mechanical ventilation is breathing through a narrow endotracheal tube. Endotracheal tube is narrower from the airway, so this does mean more resistant. So he is his inspiratory through the narrow endotracheal tube means a lot of resistance, means a lot of work of breathing. So you will support his breath against this narrow endotracheal tube and the long endotracheal tube. You know, there is a long dead space here. So you should support it. This is a comic. If you are not Egyptian, if you are not more than a 35-year-old, you will not get it, but it does mean there is a long dead space. Pressure support ventilation can be used alone. Yes, there is a mode called the pressure support ventilation, and it is the only spontaneous mode of mechanical ventilation is the pressure support ventilation. Is the spontaneous not mandatory? Yes, that is me. That should be the only trigger is the patient. There is no time trigger here. It's a spontaneous non-mandatory. Yes, so there is no respiratory rate. You do not give the patient a set tidal volume, a high pressure. Yes, so there is a less risk of barotrauma. It's for weaning, sure. Now we can set a story of a patient came to you in a respiratory failure. You want to initiate, put the AC mode. AC mode will give you a full ventilatory support. The patient, after 2 days, you manage the cause, sepsis, heart failure, whatsoever. You manage the cause, you can put him on SIMV plus pressure support ventilation. The patient is now ready for weaning. Put him on pressure support ventilation. You just give him a pressure supporting the spontaneous ventilation against the narrow and the long endotracheal tube. If he is good on pressure supported ventilation for a couple of hours, please take the endotracheal tube out. This is the graphs of the pressure supported ventilation. Then what to set? We talk about pressure SIMV, pressure support. We talk about AC mode. Then what to set? What does this mode mean? In any mandatory mode, you can set one of two. You can set a volume, it's called tidal volume, or you can set a pressure. If you set a volume, you ask the ventilator to give the patient a fixed tidal volume. I need this patient to take 4 or 5 or 6 or 7 or 8 ml per kg of his ideal body weight every 5 seconds. I am 100 kilograms. You need to give me, if my ideal body weight is 80, you give me 6 ml per kg. So every 5 seconds, the ventilator will give me 480 ml. That's what's called volume control. You control the volume. You control the tidal volume. So if you look at these graphs, you will. This is graphs for volume. This is graphs for flow. This is graphs for pressure. The graphs for volume should be fixed. There is no fluctuating value, because you asked him, give me 500, give me 400, give this patient 405 ml. So every single breath, the tidal volume will be 500, will be 500. That's called volume control. You are gonna control the volume. If you push the fixed volume, the ventilator will measure what's called the pressure. The pressure in the circuit, peak and the plateau. So fixed tidal volume and the fluctuating pressure. In some patient, like the children, like the patient with emphysema, with bronchial asthma, you said no, I don't want to control the volume. I want to control the pressure, so the pressure will not be high. If the pressure is high, it's gonna hurt the baby. It's gonna hurt this patient with bronchial asthma. So please, the ventilator, I'm gonna set a fixed pressure. So the ventilator will not exceed this pressure you gonna set in any breath. So every single breath, he will give a tidal volume fluctuating. But in any mean, this pressure shouldn't exceed the set value you put. Again, this is, we can read this now. What is this mode? Is AC mode. AC mode. Why? Because every breath is supported. This is called VC. What does it? VC does mean? Volume control. So you set the tidal volume. See, tidal volume is 500. So it's every single breath would be 500. In the same time, the ventilator push 500 and measure the pressure maximum. So the pressure in this airway is about 31. That's volume control. Control the volume, and the ventilator will calculate just the pressure. And the pressure control it's surely different. You set the pressure. You ask him not exceeding 30 or not exceeding here 18. So the pressure will be 18. To create this 18 millimeter mercury, the ventilator will give a very untitled volume. Now it's 448. The next press may be 450, maybe 430. So volume pressure control, you tell the pressure, you tell the ventilator to give a tidal volume. You do not know which tidal volume, but not exceeding a limit of a pressure. There is like a trick to know if you look at the graphs, how you can know which mode. If you look here, there is a constant here, something like sharp sign. You look here, this is sharp sign. If you found sharp sign in the pressure, it's volume control. If you found the sharp sign in the graphs of the pressure in the volume, it's a pressure control. So it's just a trick, but as we can see, the ventilator supply you with every data about the mode. So we talk about the volume control, pressure control. Is there in another mode? Yeah, it's a mode of a pressure. It's called BiPAP, bi-level positive airway pressure. By level of pressure. So you set two pressures called inspiratory positive airway pressure and expiratory positive airway pressure. Why? Why we should set two pressures? Because the spontaneous breathing, again, back to the physiology. In the spontaneous breathing, I can take air. I can take if I'm a mechanically ventilated patient, the inspiration will be supported in this mode with pressure called inspiratory positive airway pressure. Then I'm gonna push air out. When during my expiration as a patient, I didn't want high pressure because the expiration is a passive process. So you shouldn't apply high pressure in face of your patient. And this is the idea of this mode. They apply two pressures. Pressure in the inspiratory will be higher one, and the pressure during the expiratory will be a lower one. We can see in this set, this is inspiratory positive airway pressure of 10. So the pressure will not will just be 10. But at the expiratory, it will be 5. What does it mean? That the patient will take the inspiration on a higher pressure. Here is 15. But on expiration, it will be over only 5. So you respect the physiology. The patient you supported the inspiration of the patient with 15 millimeter mercury, and this is good for him. This pressure creates tidal volume about 450, and it's good for his lung. But while the patient getting the air out, you decrease the pressure in front of him, so it's a little bit easy to get the air out. BiPAP, bi-level, two types of pressure. In the inspiration, higher one, and in the expiration, is a lower one. Pressure, volume, pressure, control the pressure, calculate the volume, control the volume, calculate the pressure. I think it's a little bit confusing. So we have another problem. What should we do? We can create another mode that you can control both the tidal volume and the pressure control. It's called pressure controlled ventilation volume guarantee. Your ventilator will guarantee the volume with the lowest pressure. So you're gonna control both the pressure and volume, and this is a very fantastic mode. It's mandatory, yes, mandatory, because you set the tidal volume. You preset the tidal volume, yes. This is the control panel. You set a tidal volume of 475. But the ventilator will help you to give what you want of the tidal volume with the lowest peak pressure. So you have limiting the volutrauma, the trauma due to a higher volume, and the barotrauma, the trauma due to the pressure. This is a nice video to just elicit the difference between the PCV volume guarantee and the SIMV, the normal one. Here, look at this pressure, the shark sign in the pressure, so it's volume control. I'm gonna use pressure control ventilation with volume guarantee. Look at this, this is the pressure. It's different, yes, it's different. It's different, yes, because this is the SIMV. Now, the pressure control ventilation. Look at the pressure waves, it's a little bit different. Why it's different? Because you asked the ventilator not exceeding a pressure. So he will give you a tidal volume of 500 with the lowest pressure and not exceeding what you want the ventilator not to exceed. Again, this is the volume, this is the SIMV volume control. You can see, sorry, here. This is the pressure control volume guarantee, controlling the pressure. This is the pressure. Now you will find SIMV, the pressure, you know, like the shark. I hope it's clear. Just to invasive mode, the pressure can read it, but I can also the panel, the set panel. Anyway, pressure releasing ventilation mode, it's a mode for recruitment. You set two sets. One set, you ask the patient to take the air inspiration on high pressure for high time. So it's called P high, this is the high pressure, and the T high for 5 seconds. Look at this. Here, the patient inspiration will be over 30 millimeter mercury for 5 seconds. Then the patient, you give him a time, this is at low time, called the T low, with low pressure up to 0 pressure to get the pressure out. So what's the difference between this pressure and another pressures? That there is no respiratory rate. You ask the patient, you ask the ventilator to make the patient to apply pressure of 30 millimeter mercury for 5 seconds. Your patient will inspire on this pressure. 30 millimeter mercury for 5 seconds, high pressure for high time, then you will recruit all the alveoli. You will open the whole alveoli. Then the patient is allowed to expire to get the air out, yes, in a low time with low pressure, because after 30 millimeter mercury, the patient trying to get air out, you need no pressure in face of it. The airway pressure releasing ventilator is the pressure control. Yes, you set a pressure high for inspiration, pressure low for expiration. Something like the BiPAP, but it's different because the high pressure will be applied for what called T high. T high is T high is the time of the high pressure. You ask the ventilator to make 25 millimeter mercury for 5 seconds. This high pressure, this high time will open all the alveoli of the chest. So this mode is called recruitment mode in cases of ARDS. I think it's not common, but they were using it in US for patients of ARDS, especially before lung transplant. This is the patient will take a breath on this high pressure, then will get the air out on this low pressure, which is 0. Case report. Now you have a patient, 4-year-old gentleman presented at the ER. The patient is fully conscious. His blood pressure is 110/100. There is rails all through his chest. The transthoracic echo show with myopathic heart, and the lung ultrasound show all this reverberation or this P lines, which means congested lung. Now, myopathic heart with congested lung, I think it's cardiogenic pulmonary edema. You are gonna put him. You should put or place endotracheal tube to supply a mechanical ventilation for this patient, especially that his saturation is 80% and not increased with oxygen mask. The patient is fully conscious. You are gonna sedate him. You are gonna push some relaxant just to give him some air. He is not in respiratory failure. He is in congestion due to the myopathic heart. If you give this heart some rest with dilators, with diuretics, everything will be good. But so the question, should you put endotracheal tube to apply ventilation? No. Why? Because this is our half or second half of our lecture about the non-invasive ventilation. You shouldn't put endotracheal tube to give a ventilator support. You can supply the support through a mask through the nose called the nasal mask, or through the face called the face mask. The face mask of non-invasive ventilation has two types. This type, there is no hole. It's called non-venting mask. What does it mean? Double circle. The air will come from the ventilator to the patient, then from the patient to the ventilator by double circuit, by double breathing circuit. If we can see here, there is a hole. It's called the venting mask. In the venting mask, you need just one tube pushing the air from the ventilator to the patient. Then the expiration will be through this hole. Nasal mask, face mask, venting mask, and the non-venting mask, and this one is a venting mask. What about the mood? The mood is non-invasive CPAP and the non-invasive BiPAP. We know the BiPAP. What about the non-invasive CPAP? The trick or the tip here, you should go to the standby who ask the ventilator to supply non-invasive ventilation, because it's a little bit different in the pressure and the flow. You should announce the ventilator first that it's non-invasive, not invasive ventilation. The non-invasive CPAP, you apply the mask to the face or to the nose of the patient, then give him continuous positive airway pressure. So the patient here will take both inspiration and expiration on the same pressure. Here is about 50. It will give him this pressure support, will recruit the lung, will give him some sort of support, so his respiratory rate should decrease. The BiPAP we talked about, it's two variant levels of pressure. It's another, the last slide. The non-invasive CPAP and the BiPAP, the difference between them is this nice slide. This is a normal breathing. CPAP, both breathing will be on the same pressure. In the BiPAP, it will be on two different levels of pressure. As we can see, non-invasive CPAP is very annoying for the patient, as if you put hair dryer in front of their face. So BiPAP may have some compliance. The last of the question, the last of the slides is about the mechanical complication of the positive pressure ventilation, and I think it's a good stop here. If there is no time, for sure. If there is a couple of minutes, Dr. Salman.
Yes.
Yeah, the complication of positive pressure ventilation is airway trauma. If you put endotracheal tube, you can injure the airway, but the most important for the cardiology is the cardiac effects of the mechanical ventilation. And this is a very nice slide. If you apply positive pressure ventilation in this tight space called the chest cavity, you will apply positive pressure on this vein, superior vena cava and inferior vena cava. The veins will collapse, especially if your patient is dehydrated. If you collapse SVC and IVC, the prelude to the RV will be decreased. So the prelude to the heart will be decreased. This is the cause of hypotension after mechanical ventilation. In the same side, the RV pushing the air into pulmonary to the lung. You pushing positive pressure in this lung. The lung will be squeezed. The alveoli will squeeze the capillary, which will increase the pressure in the pulmonary, which is the afterload of the RV. So the RV now has no prelude, and has a higher afterload. This is a little bit burden on the RV, and this is the cause of hypotension after mechanical ventilation. But to the LV, it's a little bit different. The LV, the prelude will be decreased with the RV, if the LV is the prelude of LV. What about the afterload of the LV? It will be decreased with mechanical ventilation, and I think this is the cause. When you apply mechanical ventilation for a patient in heart failure, myopathic ejection fraction 35-30, the patient cardiac output may be a little bit increased for many reasons. The first reason that you oxygenate, you give a higher oxygenation for the patient, so the performance of the myocardium will be better, so the cardiac output will be decreased, although the hypotension may be on the range. The afterload of LV, how it decreased? In the spontaneous breathing, the LV has to create pressure of 120 to overcome the aorta and to overcome the negative pressure around him in the chest cavity. you institute or you replace the negative pressure in the chest by positive pressure. So you help the LV to compete the afterload relatively. So if the pressure decreases after mechanical ventilation, maybe the cardiac output increase. The last slide is the positive pressure ventilation. When you inflate this lung, if you increase the tidal volume, you will get volutrauma. If you increase the pressure, you will get barotrauma. And the inflating the lung, deflating the lung, inflating the lung, deflating the lung, the matrix of the tissue between the alveoli will be destructed and release what's called systemic inflammatory mediators. You put the patient on ventilator on August 20, August 25, create is higher. It may be because the sepsis, but the ventilator and the inflammatory markers of the biotrauma may have a role. This is the summary of and thank you. Thank you, Dr. Manan, and sorry for this extra 5 minutes.
Yeah, thank you, Dr. Islam, for this powerful rocking lecture from the first of the course. There is one question for you on the chat.
Yeah.
Can you read it?
Yeah, just a sec, please. Is the BCB volume guarantee the same as PRVC? I didn't read this abbreviation of PRVC, pressure volume control. I can't. If you can tell me what's PRVC, I think there is no abbreviation of
abbreviation like that. I couldn't understand also.
Yeah, you know, the abbreviation of moods is very easy. BCV, pressure control ventilation.
Pressure regulated volume control.
Yeah, I think it's the same. But pressure regulating volume control. Maybe it's a mood I didn't know about it. There is a pressure control volume guarantee. She just you know, vice versa. Pressure guarantee volume control. I don't know. Maybe there is a mood of something like that. But it has the same idea that you are controlling the pressure, controlling the volume guarantee, the pressure, or controlling the volume guarantee, the pressure, or the same. If it's the same idea that you guarantee something and control another thing, finally you control both pressure and volume. Yeah, it's good. But I think it's not abbreviated something like that. But it's as we see, or as we watch it in the video, it's called BCV volume guarantee. But it may be a different company, I don't know.
It's very nice presentation. They are creative. Thank you, Doctor, for your effort. Dr. Iman.
Okay, thank you, Dr. Islam, for your wonderful presentation.
I hope it was clear.
I would like to give a notice to our doctor.
Yeah.
Okay, I just would like to inform our Islam's presentation. We are going now to continue with our set schedule, so nobody will be confused, which means that the next speaker will be Dr. Shaima Al-Sayed. It's really a pleasure always to introduce Dr. Shaima Al-Sayed, who's really a cardiology enthusiast. She's always ready to have a presentation or a workshop in any scientific activity. She's always ready and active and interested in telling us all about the new guidelines in any cardiology subject. So Dr. Shaima Al-Sayed, just a reminder, she's a senior cardiologist at Shifa Al Jazeera Medical Center here in the Kingdom of Bahrain. And her topic for today is about the central venous pressure. She will tell us extensively about the central venous pressure, how to measure it, what causes its rise and its low readings. Dr. Shaima, the platform is yours.
Thank you, Dr. Iman, for nice introduction. Good evening, dear colleague. Today I'll discuss about central venous pressure. My second part, today I'll talk about CVP per se. Second part, inshallah, tomorrow it will be about the neck veins examination, and the clinical examination is very important for our clinicians. From here. My agenda is introduction, physiology, indications, contraindications, what is the types of central line, how to insert the CVB, how to measure CVB, how to interpret, and what is the complication with CVB. Central venous catheterization first performed in 1929. Since then, the central venous access has become a mainstay to modern clinical practice. CVP catheterization, it is a catheter with a tip that lies in the proximal third of the superior vena cava near to the right atrium, or inferior vena cava may be extended to and inserted to it. Also, we can insert it in peripheral veins or proximal central . This is a change in CVP pressure is determined by change in volume of blood within the thoracic veins divided by the compliance of the right side of the heart, and the veins like superior vena cava, right atrium, inferior vena cava, right side of the heart is a capacitant part. So it is the equation, the pressure difference of CVP is the difference in the volume to the difference in the capacitance of the veins. CVP describes the pressure of the thoracic vena cava near to the right atrium. Therefore, CVP and right atrial pressure are essentially the same. CVP is an important concept in clinical cardiology because it is a major determinant in filling the pressure to the heart. So it consider to me it is the preload to the heart and to the right side of the heart, right ventricle, which regulates stroke volume through the Frank-Starling law mechanism. Therefore, CVP is increased by either how it is increased CVP by the venous blood volume. If increased, it will increase the CVP, and the decrease of the venous compliance will decrease the CVP. So caused by the decrease of the capacitance, it is by decrease the contraction of the smooth muscles of the veins, which increase the venous vascular tone and decrease compliance of the veins, so decrease this CVP measure. As we see here in the graph, there is central venous volume to central venous pressure. Now I see the difference between volume and pressure. This is the point A, B, C. B, it is increase in the venous return. It will increase the volume, it will increase the CVP pressure with me. If the increase in the venous tone, it will decrease the compliance and decrease the CVP. What is the indication and what is the purposes from CVP? Monitoring of the central venous pressure in critically ill patient after major surgery in the ICU, or infusion of irritant drugs like chemotherapy, because we know that smaller vessels and veins couldn't tolerate these irritant drugs, or like potassium also need the central line. Insertion of pacing wires. If I wanted to make temporary pacemaker for a patient, I should put the sheath or CVP. Renal replacement therapy. emergency venous access, parenteral feeding is TPN, resuscitation, the patient are intravascular depleted. So it is a guide for me for fluid replacement and medication administration for ICU patients, also monitoring to the pressure and volume in the right atrium and right side of the heart, obtain the access when the peripheral veins size are inadequate, and administration to the blood products or TPN and insert pacemaker and blood sampling. What is the relative contraindication? If the patient has a problem in bleeding tendency, like thrombocytopenia, uncorrected coagulopathy, skin infection at the site of access, obscure anatomical landmarks like fat neck or huge fat neck, hemo or pneumothorax on the contralateral side, so I couldn't perform on this side. I can choose another access. Recent surgery to other structures, nerves such as carotid endarterectomy. If there is any problem in the or surgery in carotid, we will choose another site. This is the graph or picture about patient. Already we did for him Cvp line. What is the Cvp line as we see here? This is the Cvp line, and this is the three-way cannula, and this is the manometer IV solution, and this is the ways for the manometer to the patient and to IV solution, and how it is open and how it is closed. I'll show you a small video, 5 minutes. It will conclude all of these. What is the types of the central line? We have single, double, triple, quadri, quanti, triple of the lumen. We have 5 ways, even 5 ways, but the most common is triple, as we see in most of ICU. What is the sites, common sites for CVP? Usually we use right internal jugular vein because it is the most continuous with the superior vena cava and right atrium. As we will see now in the anatomy, another photo, it is the most continuous line, right internal jugular. So we prefer it is the most common, but we can insert in another, like left internal jugular, right subclavian, left subclavian, and femoral. There is also abbreviation called BICC. It is the peripheral inserted central catheter. It is not central, it is peripheral. And I'll show also now another photo for the peripheral catheterization. This is the peripheral inserted central catheter, PICC. It is a long thin tube that is inserted through a vein in your arm, passed through the larger veins near your heart. It is very rarely BICC line may be placed in your leg if it is inaccessible to another veins. So it is very important to know also BICC. It is like we have in catheterization in cardiology. We can go to the femoral from this is the peripheral. Peripheral, it is for temporary pacemakers. This is a small illustration. This is the sternal notch. Sternal notch, it is the end of the trachea and the beginning of the manubrium sterni. And angular fluid, it is the end of the manubrium sterni, and this and the beginning of the second costal cartilage. And here's the first loop. So this is important anatomy because when we putting the CVP at this guide wire and the needle, take care from the complication to injury of the upper lobe. Neck veins, I'll illustrate it tomorrow for clinical purposes, how to examine neck veins, what is the neck veins, how to see the waves, what is the complication of the waves. This is our issue tomorrow, inshallah. This is a small illustration about the neck veins. What are they? We have on the both sides, right and left external jugular, then right and left internal jugular. Both of them, left and right, will communicate and drain in the right and left subclavian veins, then will communicate again to right and left brachiocephalic veins to drain in the superior vena cava, then right atrium. Okay, so from this illustration, we see here in the right external jugular vein, it is the most continuous line to the right atrium. This is our instruments to cannulate the internal jugular vein or any central venous axis like subclavian or right internal jugular or left internal jugular. We here see gauze and the ultrasound gel probe covers. Also, there is IV catheter, syringe needles, guide wire, lidocaine for anesthesia, safety scalpel, and the needless valves, sterile labels, Edward catheter, dilator, needle, and sterile field ready pre-filled syringes. How to insert? In certain sites, as we said before, it required to insert the catheter into the large central vein like internal jugular vein, subclavian vein, femoral vein. This site is chosen frequently, or there is high rate of successful insertion. What is available for you, what is seen for you, what is easier for you and for safety for the patient. Internal jugular vein are short and straight and relatively large, allowing easy access. However, catheter occlusion may occur as a result of head movement and may cause irritation in conscious patient. This site is often chosen according to recognizable anatomical landmark, marking insertion and device easier, and the availability to you if there is a transducer or if there is ultrasound beside you or no. Subclavian cannulation recommended as it is more comfortable for the patient because it is away from the neck and movements like that. It is below the clavicle, so it is preferable to the patient. Because this site is positioned beneath the clavicle and the risk of pneumothorax is during insertion may be high. This site provides rapid central access during an emergency such as a cardiac arrest. So the vein is near to the, if the vein is near to the groin, you can have a risk to the associated infection like femoral veins, and reported to be uncomfortable for many patients to disencourage his movement after that if you access the femoral vein. So now the manometer or monitoring for the patient Cvp line, then the nurses will help us for manometer or monitoring kipple, pressure bag. We will see small video. It will conclude all of these and make it more practical for us. Transducer line tubing, and then 1 liter normal saline hyperonized. It is a very important step. 3-way stop scope. And word generally manometers. Note in احنا يبقى post CVP measurements method are reliable if you used it correctly. How to measure by manometer system or transducer system? Manometer system enable intermittent reading and is less accurate than the transducer system. The nurse can be stopped and after that she can take reading after 2 or 3 hours. But transducer system is very important and it is more now applicable in our ICU and wards because it is a continuous reading and which is displayed on monitor. This is how to measure the CVP using manometer. I'll not say it again here. I'll make it in a small video. It will analyze all of these steps, how to read it. How to interpret? It is very important step, how to interpret the CVP waves. As we see here, CVP waves, we have 3 positive and 2 negative waves. 3 positive waves, A, C, V, and 2 negative waves, X and Y, okay? I'll make it easy as I can because it is tough. I know we can make it a landmark by the abbreviations to make it easy to not forget. As we see here, A wave, it is considered atrial contraction. It means atrium will contract, squeeze to make the blood going from the superior vena cava and right atrium to the right ventricle. It is considering with P wave on the on the ECG lead. P wave, it will correspond A wave, okay? It means this is here the ventricle is relaxing diastole. So we have here a wave. It is A from atrium. This is from atrial contraction, correlate with P wave on the ECG. If it is not appear on the graph, it means there is atrial fibrillation, because now the atrium can't contract, it is fibrillating. So it is very important in AF patient, we will not see A wave. C wave, it is C cusp, A atrial contraction, C cusp, to not be forgotten. C cusp of the tricuspid valve. This is cusp will protrude backward through the atrium as the right ventricle begin to contract. So it corresponds the QRS complex on ECG. So we talk now A wave, it is positive wave, it is atrial contraction, as I told. It will be corresponds the P wave on ECG, and it will be absent in AF patient. C is cusp of the tricuspid valve. It will bulge, so it will make for me a positive wave. Okay, it will correspond the QRS complex on the ECG. So what is the after that the wave is X descent? I'll take the third positive one first is V wave. V venous return. V venous return, to not be forgotten. V wave, this is the third positive wave. It is mean the filling from the right atrium, from the superior vena cava and inferior vena cava, and this is the back pressure wave. It will correspond T wave on the ECG. So for conclusion again, we have A, C, V. This is three positive waves on the CVP pressure waves on the monitor, you will see. A of the atrial contraction, it will correspond P wave on ECG. C is the cusp bulging of the tricuspid, and it will correspond to QRS on ECG. V, venous return, it is the filling pressure on the right side, and it is correspond T wave on the ECG. V wave also giving impression about if it is very huge V wave, you see on the monitor what is corresponds the tricuspid competence, or means tricuspid regurgitation. It means the blood returning to the right atrium through the valve too much. It making more for you huge or giant V waves, prominent V wave. This is the pressure decrease caused by the tricuspid valve V wave opening in the early ventricular diastole, and it happened before the P wave ECG and a loss of Y descent suggests tamponade. I'll take again X descent and Y descent. This is the two negative waves in the ACVXY, CVP pressure. This is X wave. This is the movement of the right ventricle, which the descent as it contracts. Downward movement decreases the pressure in the right atrium at this stage. There is atrial diastolic relaxation, which further decreases the right atrial pressure. It happens before the T wave on the ECG. Okay, and on the after that, what is the abnormalities of the CVP? If you find a wave absent, it means AF patient, okay? Because A, as we said, it is atrial contraction. If it is absent, it means the patient is AF. If you will see the C wave is huge, ventricular contraction, tricuspid bulge, you won't see this. And X descent, it is atrial relaxation. V, venous filling, venous return, ventricular contraction. Y descent is ventricular filling, tricuspid open. So abnormality in A wave, as we see, if we found A wave is huge, high E wave. A wave resistance to the right atrial emitting may occur at or beyond tricuspid valve, example, pulmonary hypertension and rheumatic tricuspid stenosis. right atrial mass of all thrombus. Canon E wave, canon, it means very pulling, it is very huge, large positive venous pulse during A wave. It occurs when the atrium and the ventricle contract across the tricuspid valve with each other. It is common in common heart block, okay? Complete atrioventricular block. It is complete third degree heart block, and premature atrial junction ventricular beats and ventricular tachycardias can occur. Absent A wave, we said also it is occur in AF, atrial fibrillation patient. What is the abnormality in V wave? If it is elevated, it means that tricuspid valve bulges two more, and it is the ventricle contracts if the tricuspid valve does not close well, and the jet of the blood shoots into the right atrium. It means, for example, tricuspid regurgitation, if significant, accompanied with pulsatile liver, okay, all over that. We see here the hepatojugular, okay. You will also hear murmur on the tricuspid regurgitation, pansystolic murmurs that increase on inspiration. Other signs, there is also very important sign in GVP is posmal sign. What is posmal sign? It is neck vein raise in inspiration. We will talk about this in details tomorrow in neck vein examination. There is a neck vein raise in inspiration. It is the opposite of the normal. It should be decrease. When we take inspiration, the blood volume, it will decrease, but here it will be opposite to the normal. It will raise in inspiration rather than fall, often a sign of pericardial tamponade or right heart failure, acute right ventricular myocardial infarction. What is the Friedreich sign? It is exaggerated X wave or diastolic collapse of the neck veins from the constricted pericarditis. CVP reading is very important. Clinical features like dyspnea with pulmonary crepitation, tachycardia, hepatomegaly, ascites, peripheral edema, venous congestion, and dilatation of the face and the neck, associated signs. And how to diagnose that in the CVP reading is high. Diagnosis as heart failure patient or cardiac tamponade or tension pneumothorax. Treatment, diuretics may be required in tropes and treat the underlying cause. What is the complication? Complication of the CVP access cannulation on the arterial side, puncture or hematoma, or may make fistula, pneumothorax, chylothorax, nerve injury, air embolus, catheter or while shearing and tearing, right atrial or right ventricular perforation. What is the complication of the catheter presence? May be cause thrombosis or thromboembolism or bleeding tendency or infection, sepsis, endocarditis, arrhythmias, and hydrothorax. This is the CVP is invasive method. Can we measure CVP by non-invasive method? Yes. How? By echocardiogram. As a cardiology, doing echocardiography, I can measure the CVP without doing the insertion by invasive method. How? I'll put the transducer on the apical floor or epigastric area and bring the subcostal view. I'll bring the IVC diameter. This is the view by the echocardiogram. It is non-invasive method, and it is very helpful in critically ill patient. You need to diagnose the patient very rapidly. It is very malleable and very easy method to assess the CVP. How? I bring the probe and put in the subcostal view and measure the IVC. As we see here, IVC, it is under the lever, and it is direct continuation with the right atrium, as we see here. Okay, I'll measure this by the caliper of the machine. It will correspond according to these numbers. IVC diameter, if less than 1.5 centimeter, it means, and the collapsible, it is collapsible with you with respiration, 100%, it means the CVB is 0 to 5. If the diameter is 1.5 to 2.5 centimeters, and the collapsibility is more than 50% partial collapse, it means that the CVB is 6 to 10%. If the diameter is 1.5 to 2.5 centimeter and the collapsible is less than 50%, it means the CVB is higher, is 11 to 15. If the diameter is more than 2.5 centimeters and the collapsible partial less than 50%, it means the CVB is 16 to 20. If the IVC diameter is more 2.5 and no collapsible 0%, it means the CVB is very high and the patient is in pulmonary hypertension and the CVB is more than 20. There is two methods, new articles I saw, so I'll give hint about it. There is a new method for measuring CVB. How? It is non-invasive and very easy, called infrared sensor spectroscopy. This is using infrared machine on the veins, and it will give you colors. According to which you will measure the Cvp column and the waves. Another method, it is invasive. This is also a new method. It is very easy, called the compass. Gives the clinician pressure data quickly and conveniently and provide a faster treatment path and confirmation success of the critical treatment. As we see here, it is also used in the puncture of the lumbar punctures. It gives you the pressure before. It's very easy. Now I finished my lecture. Ahmed will give us the video, a small video about CVB from ICU Prague colleagues. It is very feasible and give us the, thank you. Give us small, Ahmed, please. Can you share the video?
Yeah, he's sharing now, Dr. Shaima.
Hi guys, welcome to Prague ICU. My name is Teresa and today we are going to show you how to set up a central venous transducer. For invasive blood pressure monitoring, either venous or arterial, you need to prepare following equipment. Normal saline 500 cc, transducer kit which comes along with flush tubing and pressure tubing, as you can see on the video. You can also see a transducer cable, pressure bag and transducer holder and an IV pole which is already prepared at the bedside. First, you set up all your tubing which you will need for the IV line. Then you put 5,000 units of heparin into the saline bag. In the video you see it's a 1 milliliter. You then label the bag with the name of the medication, date and time. Then you spike the bag with tubing. and put it into the pressure bag and inflate it to 300 millimeters of Ag to sufficiently contract the systematic pressure. You turn the bag upside down for priming the tubing system. You need to make sure there are no air bubbles left before connecting the line to the patient. And now you can see I'm taking everything to the bedside. At the bedside, you set the transducer into its holder fixed on the IV pole. You need to make sure that the tubing that is going to the patient is facing upwards. The cable for the transducer is facing downwards. Again, you can flush the catheter to allow the air come out of the system. Then you connect the pressure tubing tip to the distal lumen of the central venous catheter. Most of the time, the distal tip has a brown color. Then connect the transducer cable to the transducer and the monitoring device. For accurate pressure detection, patients should be placed in supine position, and the transducer needs to be leveled at the patient's phlebostatic axis. It is located by drawing an imaginary line from the fourth intercostal space and the sternum and finding its intersection with an imaginary line drawn down the center of the chest below the axilla. Close the stopcock towards the patient and open it to the atmospheric pressure as seen on the video. Press 0 on the monitor and wait until the actual 0 appears on the screen. Turn the three-way stopcock back to its starting position with closed cap and you can begin your pressure reading. You can also optimize the wave for accurate reading as well. And now, as you can see, we have very nice Cvp line on the monitor. Thank you for watching Prague ICU and stay tuned for more educational videos.
Thank you, dear my colleagues. I hope it is clear, and if there is any question, I am ready.
Yeah, Dr. Shaima, can you open please the Q&A box? There are a couple of questions over there. Narges is asking why she cannot see a C wave.
Why we cannot see the C wave?
Yes.
You can see the C wave because it is on the monitor. We can see it, no problem. It is on the monitor. All the waves are present. A, C, V, everything, X and Y descent. You will see all these waves. I put the pictures of the waves on the screen, and you will see it. It is cast. On the neck veins, it is another issue. We will discuss it tomorrow, but not on the monitor. Monitor, you will see A, C, V, and X and Y, all waves are be seen. Other alternative or CRPSI. I don't know what is this.
CRPSI, I don't know either. Okay, actually everybody likes your presentation and they find it very easy to understand, even the pediatric cardiologist from Iraq. Causes of malposition of CVP.
Malposition, anatomy, maybe anatomy of the, it is abnormal anatomy, or it is difficult fat, maybe from making complication like pneumothorax, it make it up. So Peter, you can guide the CVP by ultrasound when you introduce it.
Okay. Any other questions? Actually, we already told them, Dr. Shaima, that they can review the video you have just shared on the Education Plus YouTube channel. So they will have it all the time, so they can follow up with it. We'll move on.
I'll introduce my colleague, Dr.
Please. Thank you so much for your presentation. Yeah, please.
I'm happy to introduce Dr. Vinayak. He's a Chief Resident Department of Cardiology, Mohammed bin Khalifa Specialist Cardiac Center. Great honor to be a part with us in ICU workshop. He will discuss with us ecodynamics in ICU. Thank you, Doctor.
Thank you very much. Thank you very much for the kind words. So am I audible and my slides visible?
Yes, Dr. Vinayak, yes, very well.
Thank you.
Can see you and hear you very well.
Thank you. I'll just make it full screen. Yeah. So thank you very much. At the outset, I would like to thank all my organizers who gave me the opportunity to present. So I'll be drifting a little bit. I'll change gears from the invasive triple lumen catheters like CVP, Schwann-Ganz, the PA catheters, into a totally non-invasive modality, that is echocardiography. So the topic of interest today is ecodynamics for ICU, and I'll be trying to convince you that it could be used as a non-invasive catheter for CVP monitoring, for PA catheter information like pulmonary capillary wedge pressure and all that. So in this topic particularly, I will not be discussing the methodology of echo because that is totally out of the scope of presentation. Possibly, I will try to entice you and entertain the fact that echo could be used in ICU, and I'll show you how. So the outline of my presentation would be what exactly is ecodynamic and why echo? Why not PA catheter like Schwann-Ganz conventionally when we use it? Which echo parameters to monitor? And can we combine echo with other non-invasive modalities like pulse contour analysis or transpulmonary thermodilution? My intensivist friends would be more better in explaining them. And I'll end up my presentation with a case study just to convince you. So how do we define ecodynamics? Yeah. So this is from the guideline. In fact, there is a guideline for echo being used as a hemodynamic monitoring tool. So echo is being used as a monitoring tool if after a diagnostic assessment, repetitive hemodynamic or anatomic assessments are made over a period of minutes, hours, or days in the same patient to guide management. It refers to the use of focused echoes as a hemodynamic tool in critical care setting, implying a smooth drift from classical cardiology use to a more intensive care, personalized and adjusted use. In critical care settings, any little but correctly interpreted echo data can make significant difference to the patient management. So why echo and why not a PA catheter? So basically, I would like to say the rise and fall, the obituary timeline of PA catheter. Basically, PA catheter came in 1970s. It became so famous that in 1980s, up to 40% of critically ill patients underwent PA catheter. It became the cornerstone of critical care and hallmark of ICU. And this all occurred despite no evidence of safety, accuracy, or benefit of the device. In the mid-1980s, some editorials got published challenging its routine use, and they demanded for some randomized controlled trials on safety and outcome of these catheters. And in 1996, finally, a trial came where it showed 24% increased risk of death who received PA catheter within 24 hours of admission. That's quite a huge number, actually. And finally, in 2003, there was a large randomized controlled trial with nearly 2,000 patients, which showed there is no benefit between PA catheter and the standard of care. But I'd like to tell you that of late, there have been some studies which have established the safety of PA catheters, and in some patients where it is mandate. And the late realizations about PA catheter was the data regarding cardiac output and wedge may be inaccurate and erroneous due to a multitude of technical factors. PA catheter has its own complications like PA rupture, thrombosis, bacteremia, infective endocarditis, and all that. And there could be a potential harm due to own physician knowledge deficits. And information obtained from PA catheter may not be useful to manage critically ill patients. In fact, it may result in overestimation of many cases. The only potential benefit of PA catheter presently is in diagnosing and monitoring patients with pulmonary hypertension. In our center, we use it mainly for patients with cardiogenic shock who are critically ill. So what is the evidence? If I'm talking so much against PA catheter, what is the echo evidence? So there was a recent systematic review and meta-analysis where cardiac output measurements were done by two methods. It was by the conventional thermodilution method by PA catheter and other by echo. So electronic databases were searched till 2019. 68 studies were identified out of 43 represented data on cardiac output. And to the surprise, there was no significant difference found between the cardiac output measurements by thermodilution method and by echo. Both methods in majority of the cases would be interchangeable in most of the conditions. So there came the resurgence of echo and other non-invasive modalities wherein they could get some hemodynamic parameters from echo itself in the ICU. Bottom is the reference. I'll just take my pointer. Yeah. So bottom is the reference from where this meta-analysis data is being reviewed. So what are the parameters in echo which you can evaluate? So I'll be very brief, and for intensivist, a lot detailed echo study is not required. And let me put forward a point that even if you're not doing an echo, when you get an echo done, you can utilize these parameters. You can ask for specific parameters from your cardiologist or from the echo technician itself. So the important thing is LV size and function, the stroke volume, cardiac output, and cardiac index. Preload, the fluid responsiveness. This is going to be very, very important for intensivist. And of course, the LA and the LV filling pressure. It's actually more important, but I don't see it being utilized more often in the ICUs. And now the afterload. Apart from preload, even the afterload component is getting a lot of attraction recently. And right heart is no more a passive bystander. It shouldn't be neglected anymore. So we'll take some parameters of the right heart also in intensive care units. So for LV, simple chamber size has to be measured serially for the assessment of the volume status. And we take this first view of the echo, which is parasternal long axis view, left atrium, left ventricle, right ventricle, separated by interventricular septum. So this is the view where you can serially measure your LV dimensions, because in ICU, echo has to be repeated many times because of the dynamic changes in ICU. So one view is more than enough so that we can repeat on the same and have a good understanding. So this long axis dimensions is easier to acquire and compare, which is being less prone to improper alignment. Reference ranges are there in all the guidelines. So hypovolemia is best monitored with LV end diastolic diameter as best monitored with LV end diastolic diameter, not the end systolic diameter, because even low end systolic diameter can reflect low systemic vascular resistance, increased inotropic state, and reduced ventricular filling. And there is some dissimilar perception of LV dilation by cardiologists and intervenists. When LV dilates, for the cardiologist, it is never a good thing because they start thinking about post-MI LV dilatation. If the patient is valvular heart disease, LV dilatation. But for an intensivist, it might be a good thing because suppose the patient comes with a sepsis and after a while it goes into septic or distributive shock and LV dilates, it might be a compensatory mechanism for the heart. So the perception of echo for an intensivist and cardiologist is going to be a lot different. You will see in further slides. Second is LV function. Now, it's not about EF. I think as an intensivist, even as a junior, you should not look at the echo report only for LV ejection fraction. Though it is considered the most useful echo value, but it is wrongly equated to the contractile function of the heart. If you have to really assess the contractile function of the heart, it has to be independent of preload, afterload, and contractility. But LV ejection fraction is a fraction of end-diastolic volume ejected during systole, is an end product of preload, afterload, and contractile function. So it is very, very load dependent. Now, how do we calculate ejection fraction? Difference between end-diastolic volume and end-systolic volume divided by LV end-diastolic volume. So it is a fraction of end-diastolic volume which is being ejected. And the difference between end-diastolic volume and end-systolic volume is stroke volume. Stroke volume is the one which is of major interest to the intensivist because it remains stable despite low ejection fraction and high volumes. Suppose your ejection fraction is low. You shouldn't be taking decision only on the ejection fraction. You should take the volumes and assess the stroke volume, because the stroke volume might be the same. Now, this is a common scenario you might see in ICU. You get a critically sick septic patient might come, and you get an echo done, and you have this hyperdynamic kissing ventricle. We call it as left ventricular kissing ventricle. So how do you approach this? Because most of, you can see how the left ventricle is vigorously contracting. It's a short axis stack of the left ventricle. There is a good amount of endocardial thickening and inward movement of the endocardium. But how do you approach this in terms of management? Are you going to give fluids to all? I think no, actually. So the thing is, when your echo person does the echo, you look into the numbers. First thing, if the end systolic volume or end systolic diameter is reduced, obviously it will be reduced in all the cases. Look at this, it is so much reduced here. Then you assess the end diastolic diameter. Even if the end diastolic diameter is reduced, it is hypovolemia and blood loss, wherein you need fluids, you need blood for resuscitation. But in case the end diastolic volume is same or increased, it implies something else. It implies it could be a septic shock, which has gone and caused some element of myocardial dysfunction. It implies vasodilation, anaphylaxis. Inotropes have started and created that effect. As I told, LV dilatation is a protective effect, and severe MR and left to right shunt. So there is the basic difference. If the end systolic volume and end diastolic volume both are reduced, you're dealing with a pure hypovolemia or an acute blood loss. But if the end diastolic volume remains the same or is increased with a decrease in end systolic volume, we think about alternate diagnosis, even before you get the detailed report. Now comes the stroke volume and cardiac output. Stroke volume is very important. Cardiac output probably is the holy grail of intensivists from where they start taking their decisions. You could see the relationship between the stroke volume, preload, contractility. Stroke volume is nothing but preload into contractility. It follows very closely the Frank-Starling mechanism, as Dr. Sharma was explaining in the previous lecture. Stroke volume again equals 1 after afterload. So you can imagine that if you have an assessment of a stroke volume, you are assessing the contractility in a closer way. It is though not equivalent, it is more attractive than LV ejection fraction for intensivists, as I have mentioned to you. And what is cardiac output? Nothing but stroke volume into heart rate. And cardiac index is cardiac output divided by body surface area. So with a simple estimate of stroke volume, you have an assessment of cardiac output and cardiac index. How do you assess stroke volume? If we go back to our basic physics, so stroke volume is nothing but flow, and flow is area into velocity. So stroke volume in most of our cases is assessed by the cross-sectional area of the left ventricular outflow tract and velocity time integral of the left ventricular outflow tract. It is the preferred method, though there are many other methods, but you have to keep one standard method. As I said, echo is repeatable in ICUs. Just keep one method and keep following that for repeat measurements. As I said, the diameter and the pulse wave Doppler of LVOT. LVOT is left ventricular outflow tract, and VTI is the velocity time integral. It is a column of the blood which blood travels in the left ventricular outflow tract, and they measure the area into velocity to get the flow. So most of the times, Doppler comes with its own recipe of a lot of improper alignments and a lot of errors. So in those cases, you can only take stroke distance or the LVOT VTI for decision making. So as seen here, this is the parasternal long axis view. This is the aortic wall, and below the aortic wall is the left ventricular outflow tract. We take the diameter of the left ventricular outflow tract and eventually calculate the area of the left ventricular outflow tract. And this is the flow across the left ventricular outflow tract, which we call as VTI. So we measure the VTI in here. So as you can see, the area was 3.3, the VTI was 19 centimeters. The stroke volume of this patient is 63 ml. Heart rate of this patient is 92. When once we multiply it, we get a cardiac output of 5.8 liters per minute. Additionally, if you know the body surface area, you can index it and you get a cardiac index also. So as easy as that, but you have to do it repeatedly to get perfection. So now comes the most important part of intensivist, and obviously, as Dr. Shaima mentioned, CVP assessment of RA pressure, preload. So preload fluid responsiveness, I would like to put it that way. Is it only IVC? Maybe I will try to change your perception after this presentation that is it only IVC that you have to look into. So what does flow responsiveness means? Fluid responsiveness. So what does fluid responsiveness means? It implies that the volume infused into venous circulation translates into improved flow. And it is assessed through interrogation of flow across the aortic wall and or respiratory variability of SVC and IEC. All this while, we think that if we assess the IVC, we have an assessment of flow status. In the sense, if IVC is small, you give a lot of fluids. If IVC is flat or big, then you stop fluids. Is it always the same? No. We can do other things also. Like I mentioned here, you can assess interrogation of flow through the aortic wall as well. And it would come as a surprise to you that the velocity, the Vmax across the aortic flow or the left ventricular outflow tract flow is most sensitive. It's not the IVC which is more sensitive, or not only IVC. So there are many other modalities wherein you should assess to really give fluid responsiveness, to really assess for fluid responsiveness. IVC has its own limitations. So if the low tidal volume, spontaneously breathing patients, spontaneous respiratory efforts, low lung compliance, and high frequency ventilation can invalidate IVC for fluid responsiveness. You cannot rely only on the IVC. However, IVC is quite easy to do, as Dr. Shaima explained. You put your probe in the subcostal, turn it counterclockwise, get a sagittal view of IVC. It can be used in arrhythmias. You can't use, in arrhythmias, you cannot use the left ventricular outflow or aortic flow. And then we have static and dynamic parameters of the flow, fluid responsiveness by integrating other indices, which I would explain. All are echo parameters. So this has been covered, obviously, but what I want you to remember only two things: the dimension of 21 millimeters of IVC and the collapsibility of 50%. If the dimension is less than 21 millimeters and the collapsibility is more than 50%, as you can see here, the IVC is collapsing compared to the maximum dimension. The pressure is around 0 to 5 millimeters of mercury. But if the dimension is more than 21 and the collapsibility of the IVC is less than 50%, obviously the pressure is quite high, between 10 to 20. From a guideline perspective, they have given it as 15 millimeters of mercury. Anything in the middle is indeterminate, and you can give it a number of 8 millimeters of mercury. So with this simple echo view, in fact, many of them don't even measure it in ICU. They just look at it and take a decision. So what are the static parameters? There are many, but the thing is, the more you integrate and you can avoid the invasive catheters. So obviously, first is the small LV. Forget about the numbers. The numbers are there in literature and the guidelines. If you see a small LV, as I had shown you in the example, the patient is underfilled, requires fluids. If the LV is hypercontractile, if there is a lot of hyperkinesia, usually kissing papillary muscles, or your echocardiographer has given an EF of more than 70%, patient needs fluids. If there is a pseudo LV hypertrophy, which we call it as concentric remodeling, that is, it means it's a thick ventricle with a small heart. So even they need fluids. And if the echocardiographer has reported as LVOT obstruction with systolic anterior motion of the mitral valve, these patients are in failure. But you should not use anti-failure medications in this. If you have this finding, you still need fluid. And if a small right ventricle is there, a small inferior vena cava, as I have mentioned, the patient needs fluids. So they have given a diameter of less than 10 millimeters as a patient who would respond to the fluids if you give them. So these are the static parameters. But in clinical practice, in ICU, it is the dynamic parameters which are more important. The dynamic parameters could be based on heart-lung interaction or without heart-lung interaction. And there is something called Ivc Collapsibility Index and Ivc Distensibility Index. Because if I would tell you, most of the studies of IVC were done on mechanically ventilated patients. IVC gets little inaccurate and invalidated when you're trying to do in spontaneously breathing patients. So we try to measure different IVC indices in spontaneously breathing patient and mechanically ventilated patients. As I have seen, the collapsibility, if it is more than 45%, it is measured as maximum dimension minus minimum dimension or maximum dimension. Then it is for spontaneously breathing patient, that the patient might respond to the fluids. Wherein for the mechanically ventilated patient, it is distensibility index which matters. But as I said, more than IVC indices, it is the aortic flow respiratory changes in mechanically ventilated patients. Don't go with these complicated equations. They would be available again in the literature. What I mean to say by these equations is that if you have increased variability in the flow, as I would show you, if you have increased variability in the flow, they would respond to the fluids. On the right-hand side where I'm marking out, this is the left ventricular outflow tract Doppler. And you can see how small and big the Doppler are. So there is so much of variability. And after you give the fluids, they have come to a static level, actually. They are more or less equal. So if you have increased variability in air, they do respond to the fluids. Then you have this IVC. Obviously, it is this is an IVC, which is quite very well collapsing. You can see the maximum dimension is 2.8 centimeters and the minimum is 1.1 centimeter. So this is a patient which would respond to a fluid. And the dynamic parameters, I'm not sure whether my intensivist friends really do it, but this is a very important test, and there is very good data that if you do this test in ICU, you can really assess the fluid responsiveness well. The most famous test is passive leg raising test, and most of the beds in ICU are automated, and it just consists of measuring the hemodynamic effects of leg elevation to 45 degrees. So basically, it's a simple way to perform the postural maneuver. It is to transfer the patient from a semi-recumbent posture to a passive leg raising posture. And when you do this, with an echo, you start measuring LVOT parameters. You get a stroke volume estimate, cardiac output estimate. These are not many parameters, by the way. If you just measure LVOT VTI, you get all this automatically. And this has to be recorded at the baseline, that is in this position, and after 1 minute when the patient's leg is elevated. Actually. Okay, so then you have those numbers, obviously. If the variability is more than 10%, even if the pulse pressure variation, even if the BP changes by more than 10%, nearly 10%, it predicts a good fluid responsiveness. And it can be used both in spontaneously breathing and mechanically ventilated patients, because we forget that there is a big amount of heart-lung interaction when the patient is ventilated. And a lot of parameters go haywire, even for invasive parameters, not even for echo. So, but this dynamic parameter is quite good enough to really get you an idea about fluid responsiveness. And this most of our anesthetist friends do. They give a mini fluid challenge with a 50 ml crystalloid solution or a 100 ml hydroxyethyl starch solution over a minute, and they try to look for changes, or a fluid challenge of 250 to 500 ml, and then see whether the patient responds to fluids or not. Again, these are the numbers which you can find in literature, or these slides are available for you to really go a little bit deep into. But try to understand the concept, what it is. So this is about preload. Now we come to LA and LV filling pressure, diastolic dysfunction. This is something which I would like to emphasize on, because I don't see it being much done with the intensivist. So normal LV diastolic function refers to a normal LV filling without increased LA pressure. Now, LV diastolic dysfunction would equate to pulmonary capillary wedge pressure. Some people would call it as LA pressure. Some people would call it as LV and diastolic pressure. But obviously, there should be no MS, no AS. It's in the patient without significant valvular heart disease. So the way we assess is mitral inflow. And the mitral inflow is divided into an early phase, which is a Doppler E wave, a small period of diastasis where there is no flow, and the late A wave, which is related to the atrial contraction. I would show these waveforms to you in the next slide. And most importantly is the tissue Doppler imaging E prime velocity. Now, even again, I emphasize the fact that even if you do not know how to perform this, you get these variables from your echo machines and try to see, make your own numbers and come at your conclusion. So the tissue Doppler E prime velocity is a sensitive indicator of a diastolic function being less load dependent. All the time in echo, at least, we are trying to find parameters which are less load dependent so that we can have more accurate diagnosis. And then we have this ratio of E by E prime, which is a very reliable estimate of LV filling pressure when ejection fraction is normal. So this is the mitral inflow conventional Doppler. And this is how a normal Doppler would look like, where this is the E wave, which reflects the early filling of the mitral wall during early diastole, and it reflects the preload as well. And then you have the A wave. In the middle, there is a diastasis that I explained. And then the A wave, which is because of the atrial contraction. This is the diastole actually. This early filling relates to the LV relaxation, and the late filling of atrial contraction relates to LV compliance. And you see, this is a normal waveform of the Doppler. As and when it gets impaired relaxation, as and when it gets progressive, the filling pressures go up higher and higher. Actually. On the bottom is we measure the tissue velocities. And we take a ratio of the blood and the tissue velocities to come at a reasonable idea of diastolic dysfunction. Okay. So just for your numbers' sake, when you see the echo reports, if your E by A ratio is more than 2, ejection fraction is reduced, your LA pressure is obviously high. So if you see a waveform something like this, where E is too high and A is very small, and the ratio is more than 2, your LA pressure is high. In fact, if the patient is on fluids, stop the fluids, start diuretics. Now, E by E prime, that is the ratio of the E wave to the tissue E wave. If that value is more than 14 and the patient's EF is normal, LA pressure is going to be high. So you can take your decisions based on this. In fact, the guideline in critical care echo has said that it is a mandate that the intensivists know this TDI parameter. If TDI is tissue Doppler imaging, if they are willing to learn courses in echo. In spontaneously breathing patients, we combine some other parameters like left atrial size and TR velocity to characterize diastolic dysfunction. So why is it so important to the intensivist? Again, you would be surprised to know that unlike cardiologists, the LV filling pressure, but not the LV ejection fraction, is correlated with mortality in ICU. It differentiates, the LV filling pressure differentiates more accurately from cardiogenic pulmonary edema from ARDS. It can limit the harmful fluid resuscitation and reasonably estimate fluid tolerability. As I showed you, if you see something like this after giving fluids and you do an echo, if you see something like this, a tall E wave and a small A wave, you have to stop fluid then and there. And high filling pressures and diastolic dysfunction are the main mechanisms in mechanical ventilation wheeling failure and not systolic dysfunction. If you're trying to wean a patient from the ventilation and you are not able to do so, and you do an echo, you find high filling pressures, you have to suspect a cardiac cause. Again, it is not the systolic dysfunction, it is the diastolic dysfunction wherein you are unable to wean the patient off the ventilation. And specifically TDI parameters of LV relaxation, even a simple E prime value can improve with fluids. Suppose the E prime is only 2, that means the preload is very low. So you improve the preload by giving him more fluids. And again, in ICU, you are always fond of numbers. I know my friends, intensivists, they are fond of numbers. What is the wedge pressure? What is the number? What is the LA pressure? You can get that by echo as well. It's not only an estimate that you can, the filling pressure is high or low. So if you want to know pulmonary capillary wedge or LA pressure while managing patients in ICU, you can get it. The most universally accepted and most widely used formula is, as I told you about E by E prime, you multiply it by 1.24 plus 1.9. It's a Nagwe formula. You get an estimate of pulmonary capillary wedge pressure. Or just E by E prime plus 4, again you can get a wedge pressure. Suppose you have a patient in ICU who has MR, who has come with sepsis and MR, and you want to assess what is the filling pressure. You don't want to put in a Schwann. So just take a systolic BP minus the MR gradient from your echo, you get an estimate of wedge pressure. Suppose you have aortic regurgitation. Your patient in ICU has aortic regurgitation. He doesn't have more of cardiac issues apart from that. You don't want to call the cardiologist, but you want to have an assessment. Get an echo done, see the diastolic BP, see the AR and diastolic gradient from the echo. Just minus it. You will get again wedge pressure. Suppose your patient has a VSD. To the VSD and diastolic gradient, if you add RA pressure, you can again get wedge pressure. So you have got lots of ways to calculate the pulmonary capillary wedge pressure in non-cardiac patients. Now this is something which is not being done. And obviously I would encourage most of my intensivist friends to do it, is the afterload assessment. It is gaining a lot of attention of late. And it's not even the echo. There are lots of non-invasive devices, which I am not very, I'm not sure about them, but they are coming up with a lot of values of afterload. So most important, obviously, the systemic vascular resistance. My friends, intensivist friends in ICU, they get very excited if they have a number of SVR, because they can play with their vasoconstrictors very easily if they have a number of an SVR. So clinically, calculations of SVR, as we all know, are used to assess the response to inotropic vasodilatory and vasoconstrictive agents. The Doppler echo is compatible and comparable to the invasive transpulmonary thermodilation technique for measuring SVR in cardiogenic shock patients. How do you calculate SVR in echo? Mean arterial pressure minus right atrial pressure divided by cardiac output. And to have a conversion into dynes, we multiply it by 80. Mean arterial pressure is simple blood pressure. I will tell you how to calculate MAP from a simple blood pressure. Right atrial pressure, as I already explained, from the IVC. And cardiac output, as I explained, from stroke volume multiplied by heart rate. The normal value is 900, 1440 dynes. And this is how you do it. I'll give you an example of how we do it. This is a bit advanced ventricular-arterial coupling, but again, it's gaining a lot of attention. And just to explain the fact that for a proper myocardial perfusion and for a proper myocardial work in any setting, whether it is sepsis, whether it is a lot of stress in ICU, there has to be a good ratio between the ventricle and the arterial system. So the ventricle is left ventricle, arterial system is the aorta. It has to be matched. They have to couple. And that coupling comes from the ratio between the arterial elastanes and the end systolic elastanes. Just to explain you, end systolic elastanes is nothing but left ventricular contractility and structure. Arterial elastanes is again nothing but arterial compliance and systolic and diastolic time intervals, aortic stiffness, and all that. And I got this value of dynamic elastanes. I took this and I'm presenting it because I saw a non-invasive device which intensivists use in ICU, and it's a hypotension prediction monitor, out of which they identified a small afterload variable called dynamic elastance. So they assess it invasively also, but we can do it non-invasively as well. Just a ratio of pulse pressure variation divided by stroke volume variation. And stroke volume variation can be easily picked up by echo. So this dynamic elastance will predict BP response, and low values can guide to the early use of vasopressors if they have this value. And by the way, if you have a low end systolic elastance, you will have a very low reserve. They don't respond to the inotropes well. So it makes a lot of sense to calculate these parameters, but probably in the future. So again, right heart hemodynamics, right ventricle is no more a passive bystander. It's not a neglected ventricle anymore. And right ventricle has got more heart-lung interaction than the left. Obviously, we know that the right heart failure is common and it's a serious diagnosis in ICU setting, very difficult to manage if right heart failure comes with some septic patient. The heart-lung interaction and the mechanical ventilation impact on RV is fundamental for hemodynamic management. What I need you to know as an intensivist is only RV size and shape, that too only the basal dimension. That too, just on the echo, compare the RV size and the LV size. If the ratio is more than 0.6, RV is dilated. You don't need to go and be very gingery about calculations. Just look at it and have an idea. Obviously, you need, for an afterload assessment, you need pressure, pulmonary artery pressures. So pulmonary artery systolic pressures and mean pulmonary arterial pressure. These are the variables which you can calculate. All of you, even in ICU, would like to know about pulmonary hypertension. Let me tell you, the definition of pulmonary hypertension is not based on pulmonary artery systolic pressures. It is based on mean pulmonary arterial pressure. Even in cardiology settings nowadays, we are measuring a lot of mean pulmonary arterial pressure. I'll tell you in a simple way how to measure it. And of course, like you have systemic vascular resistance, you have pulmonic vascular resistance and compliance as well. So how do we do it? RV size and function, just this is the apical four-chamber view. On the left side is left ventricle and the left atrium. On the right side is right ventricle and the right atrium. So you have to remember that right ventricle, anatomically right ventricle is just 1/3 of the left ventricle. Here right ventricle is in fact comparable. The measured diameter of the RV is around is more than the left ventricle. But even if I look at it in the ICU setting, I don't want to measure all this. I just have to have a look and see whether RV is dilated or not. RV function, only one parameter. Look at the TAPSE value in your echo report. TAPSE stands for tricuspid annular plane systolic excursion. So a normal value of 17 mm or more is considered to be a normal RV function. It is based on the fact that most of the fibers in the right ventricle are longitudinal fibers, and they contract and move from base to apex. As you can see my pointer, this is the base of the RV, and during contraction, it moves towards the apex. How much it moves gives an estimate of RV contraction. So here it is moving around 28 millimeters. So that's a normal RV function. Here it is hardly moving. It is around 6 millimeters. And on the left side, if you see, RV is dilated as well compared to the LV. So this patient is having severe RV dysfunction. And pulmonary artery systolic pressures, obviously your echocardiographer will look at the TR velocity, and he will look at the gradient between the right atrium and the right ventricle, add it to the CVP or the RA pressure from the echo, and get an estimate of pulmonary artery systolic pressure. This is how the TR will look on echo. But what you need to do, what you need to ask your echocardiographer is how much is mean PAP? Because even if you are putting an invasive line, you will get an estimate of mean PAP. So you'd like to correlate that invasive line parameter with an echo parameter. You just trace the TR envelope. When you trace the TR envelope, you will get the mean gradient between the RA and the RV. This is the peak gradient between the RA and the RV. We just have to get the mean gradient between the RA and the RV, add again CVP or RA pressure to it, you will get the mean pulmonary arterial pressure. Probably this would differentiate you from a smart intensive estimate. So try to get a mean PAP most often. And resistance, again, we have formulas for everything. This is a non-invasive way to calculate pulmonary vascular resistance, though it has got a moderate correlation with the right heart catheter. And there is a simple formula like TR velocity divided by RVOT VTI into 10 plus 0.16. But again, you are an intensivist, you're working in the ICU, you don't want to break your head with this, do nothing. Just look at this profile. This is a RVOT outflow Doppler profile. Ask your cardiologist or ask your echocardiographer, where is your Doppler profile? They might show you this profile. So normally it is a smooth Doppler profile. This is an outflow Doppler profile where it is the ejection of the pulmonary artery. So it's a systolic event. Now, if this Doppler profile is reducing in size and there is a notch in the Doppler profile, you can see the notch here more clearly. You can see the notch here more clearly. You can see a notch here in the mid systole. You can see a notch here in the late systole, probably an early systolic notch here. If you see this, most often you are dealing with a patient with high PVR. You don't need any invasive lines. You even don't need an echo calculation. Most often you are dealing with a patient with a high PVR. So at the most, you can combine your echo with other modalities also. I wouldn't go into the details. If with an echo, you have hypovolemia or ARDS or a cardiac dysfunction without RV impairment or with RV impairment, you can always combine your echo with transpulmonary thermodilution or a PA catheter or an echo. So this is based on the fact that echo itself is not enough. In different clinical situations, you have to use different parameters. I think I'm going ahead of time. So I wanted to show you a case study, but probably tomorrow if I get a time. So I'll end up my presentation. So most important message is obviously from an echo perspective, for an intensivist, it is the end diastolic dimension, which is more important than the end systolic dimension. It is the stroke volume, which is more important than the ejection fraction. The filling pressures, again, is more important than the ejection fraction. Don't always rely on IVC. Look at LVOT parameters also. Don't neglect RV hemodynamics in ICU. Attempt SVR estimates while deciding on vasoconstrictors. Combine echo with other devices. I couldn't talk a lot about it. Anyways, but most importantly, get an echo machine in ICU and start training. Thank you very much. And sorry for overtime.
Thank you, Doctor. It was very amazing and informative lecture. I hope to hear if there is any question.
So I think no questions. I'll
It's
introduce
very
the next
clear
speaker.
and informative.
Most probably it was a clear presentation, definitely.
I couldn't present more, but I'm sorry I went overboard. Anyways, I will try to, I'll introduce my next colleague, my next speaker. He's ready with the screen there. And he's, I can't see here actually. Yeah. So Dr. Haytham Al Saeed, the specialist anesthesia in Al-Kindi Specialized Hospital, Bahrain, is going to speak about an important topic. And it's quite a neglected topic, I thought. And there's never a right answer to which analgesic and which sedative to give it in an ICU patient. I'll be looking forward to your presentation, sir. So all yours.
Thank you.
Floor is yours.
Thank you very much. I enjoyed with your presentation. It was completely clear and more data added to my knowledge. Thank you. I start sharing my screen.
Dr. Haytham, please, can you switch on your camera, your video, share video, please?
Yes, I'm doing.
Okay, thank you.
Minutes break after.
You want to take break now?
No.
No, Dr. Haytham, no break now.
Okay.
Yes.
Just 1 minute, please.
I think I have a question. Dr. Sharma, should I answer it?
Yes, you can. On the panel?
Yeah, I see that rather than CMRI, strain rate is also beneficial for RV function. So whether it is RV failure or RV function, I'm not sure. Well, I really enjoyed this question, first of all. So definitely, yes, RV strain, not the strain rate. And in fact, the free wall strain has got a lot of prognostic information in patients with pulmonary hypertension. An RV free wall strain of less than 20% gives a bad prognosis to patients with pulmonary hypertension. So we can't get a clear value of RV ejection fraction, but yeah, the strain gives a good information about prognosis, not the diagnosis. That will be my answer for this. I hope I answered for you.
Okay, thank you.
Failure, Dr. Vinayak.
RV failure, yeah, okay, yeah,
Yes.
sure. Even RV failure secondary to pulmonary hypertension, yeah.
Okay, thank
My
you.
answer would be the same. Thank you. Yeah, I think he's ready, so I'll stop.
Yeah, Dr. Haytham, please go ahead. Dr. Haytham, yes, your mic on, please.
Yes, my mic on. You can see my screen now?
Yes, can see it.
Okay. Thank you. Sorry for this delay. We'll start with analgesia and sedation in ICU patient. Actually, many patients in ICU require ventilation for different reasons. There was an old concept that the longer the patient are on the ventilator, the more they should be unaware, which was out of sense because we created this concept of deep sedation and we are increasing the depth of sedation that we provided to the patient. Then we get super comfortable with a very deep level of sedation. Having that level of sedation make us think ICU look like unconsciousness. But now the common approach in ICU ventilated patient is analgesia-based sedation, not only sedation-based. This requires less sedation to be given to the patient and all the focus to be on analgesia. The reason for that is to keep the patient who's more awake, more alert, and at the same time pain-free. While achieving this way, we can prevent delirium, provide early rehabilitation, early liberation from ventilator and the ICU also. But still, deep sedation remains frequently used in ICU patients during first 48 hours or some cases, which we'll see later. Both pain management and sedation selection has their impact on ICU patient outcome and liberation. There are global analgesia sedation strategies that have been described and validated to improve patient outcome, promoting fast recovery and ICU liberation, which is a ABCDF bundle and a BADIS, PADIS guideline. ABCDF bundle. A, it's for pain, assessment and management of pain. B, both spontaneous awakening and both breathing trials. Both spontaneous awakening trials mean turning drugs off, letting the patient wake up with their with considerations. First is safety screen. Second, check if there's contraindication to start SATS. And if it is working, we can move to the next step to start SBTS, spontaneous breathing, with also safety screen. Usually, you are changing ventilator to BSV mode. Both SATS and SPS means that you are going to take care of the patient pain and then going to wake them up to see if they can go. If they can go through their own breath. So the sequence is A, B. C is for sedation, choosing the optimal sedation for the patient. For avoid benzodiazepine when possible, and titrating to the light sedation level. It is a concept of not too much and not too less. D for delirium assessment and management. Up to 30% of patients who went up in ICU go through a period of profound confusion that is known as ICU delirium. That delirium can lead to longer stay, which lead to high cost of ICU. And ICU delirium affect all ages. It might sound minor, but it means more time in ICU and higher risk of mortality. E, early mobilization. F, family engagement if it is possible. And R is a modified. It's added for respiratory drive, especially for ARDS. A, B, C, D, if bundle, it's not a program that we assume it's one show fits all. We can't take it out of shelf and just start use it. You should be aware that each hospital, each ICU unit has to get their own scenario. The clinical practical guideline for prevention and management of pain, agitation, sedation, delirium, immobility, and sleep disturbance in adult patient ICU is named as PADIS guidelines. These guidelines have focused on early rehabilitation and quick ICU liberation. To achieve this goal, we need to proper treatment of pain, minimizing sedation, and prevention of delirium. As we can see, the outcome of ICU depended on pain management, good choice of sedation, and sedation itself effect of the delirium occurrence. Pain assessment. Pain assessment evidence doesn't support the evaluation of vital signs alone for pain assessment. So we are using two ways to assessment pain: critical care pain observation tools and the behavior pain scale. They are the most valid and reliable method for pain assessment. For the critical care pain observation tool, we can use it to assess analgesia sedation. We can use it to assess analgesia sedation based on compliance with ventilator, facial expression, body movement, muscle tension. To assess analgesia and sedation in non-intubated patient, we can replace ventilatory compliance with vocalization of the patient. COBT value for each point can range from 0 up to 2. The total score is 8. According to the patient on the compliance of ventilator, facial expression, body movement, muscle tension, and vocalization. For behavior pain scale, also we can use compliance with ventilation, facial expression, upper limb movement. We replace ventilator compliance with vocalization in non-intubated patient. It's ranging from 1 to 4 in each point. BBS, behavior scale, it's ranging from 3 to 12. The target is to be less than 5. We consider 3 as no pain, 4 to 5 mild, 6 to 11 is unacceptable pain, 12 is the maximum pain. Better combination between COPT and the BBS is a good result outcome. Now we are going to do assessment for sedation. The Regiment Agitation Sedation Scale, RAS, and Sedation Agitation Scale, SAS, are the most valid and reliable sedation assessment tools to measure the depth of sedation in ICU. We'll start with the Sedation Agitation Scale, SAS. It's ranging from 1 to 7, where 1 represents the deeply unarousable patient, and 7 is a completely awake, dangerous, agitated patient, passing through deep sedated, calm, cooperative, only agitated, and very agitated. For Regiment Agitation Sedation Scale, it's ranging from around the 0, from minus to positive. Where -2 is light sedated patient, he is awake. Going up to +4 is combative patient, which is awake, more than agitated and dangerous. And down from -2 to -5 is a patient not awake, deeply sedated, which our target is around the 0, from alert, from around the -1 for light sedated and awake patient. For analgesia before sedation is a new concept in ICU, analgesia-based strategy, and we are going to select opioid with the fast onset, dose-dependent effect, and the ability to reduce excessive respiratory drive. However, these opioids without adverse effect like immunosuppression, drug accumulation, resulting in prolonged sedation and respiratory depression, tolerance within 48 hours withdrawal sign after discontinuation, hyperalgesia, and chronic pain syndrome with prolonged use, illness with increasing abdominal pressure and subsequent worsening of respiratory mechanism. Most of opioid used hydromorphine, fentanyl, sulfentanyl, remifentanil, and morphine. Actually, morphine used with caution in renal impairment patients. For non-opioid analgesia, the use of multimodal fashion may reduce opioid required and their side effect like gabapentin, parasternal, nifoban, lidocaine, carbamazepine, tegretol, clonidine, Brizidex, ketamine with low dose. Brizidex has its ability to provide sedation with analgesic properties without affecting respiratory depression, so it is a very good choice. Non-steroidal anti-inflammatory should be used with extreme caution in all critically ill patients with or without acute ARDS because of the high risk of side effects like immunosuppression and kidney injury effect. For ketamine induce potent analgesia without affecting the respiratory drive in low dose, make it a potential useful addition to opioid in ARDS patient ready for mechanical ventilation respiration. Infusion of ketamine more than 1 milligram per kilogram per hour induce deep sedation due to ketamine-associated anesthetic effect, along with an increased risk of hallucination and hypertension. This is a table showing the first line of analgesics of opioids: fentanyl, hydromorphine, and simofentanyl. We are comparing between the onset, offset, its analgesic effect, deep sedation, and effect on respiratory drive and delirium. For fentanyl, it's have actually all fentanyl, hydromorphine, thiofentanyl have high analgesic effect with no deep sedation, but they do reduce for the respiratory drive and mild delirium. For fentanyl, we should consider BRN or IVB bolus injection before starting of infusions. For the first line analgesics, non-opioid, paracetamol, ketamine in low doses, nifupam. Paracetamol, the one who not reduces respiratory drive and not doing deep sedation, but its analgesic effect is mild. Of course, no delirium with paracetamol. Paracetamol, the oral and the intravenous dose both equal effect. It can be given 1 gram Q6. It is associated with hypotension. Ketamine, we are using it in low dose, 0.1 to 1 milligram per kilogram per hour. If you are giving higher dose on 1 milligram, we can produce pronounced sedation. Nifupam actually is a good choice for moderate pain. It can be compared with potency of morphine. It should be avoided in patients with seizures. What is the second line of analgesics? Morphine and remifentanil. Morphine has a strong reduce for the respiratory drive. We should consider injecting BRN or IV bolus drugs before starting infusion. Histamine release is associated with hypotension, bronchospasm, and has accumulation in renal failure cases. In spite, remifentanil, no accumulation in hepatic or renal failure. For sedation, the sedative choice is dedicated by the desired depth of sedation we need and the anti-amnesic effect and easy liberation from mechanical ventilation. For the sedation, I'm using propofol, Brizidex, midazolam. Brizidex is the ideal agent. Midazolam can be used. Continuous infusion is a second choice, not the first one. Others can be used benzodiazepine, ketamine, phenobarbital, even volatile agent. For propofol and midazolam, both are GABA agonists. They reduce respiratory drive, cause immunosuppression, and induce deep sedation. Propofol is preferred over midazolam as it is less likely to result in prolonged sedation and or delirium, more titratable. Its clearance isn't dependent on liver or kidney function. However, propofol may cause propofol-related infusion syndrome at a dose higher than 60 micro per kilogram per minute. Brizidex is alpha-2 agonist. It doesn't cause immunosuppression nor respiratory drive depression, has analgesic properties. Unlike propofol and midazolam, may improve sleep and may be associated with a lower prevalence of delirium. For sedation selection, first line sedation, Brizidex, we said it is the ideal drug. Midazolam, while using midazolam, we should consider giving BRN and the intravenous also bolus. Midazolam has a high rate of delirium, which is not preferred. Propofol also it can be used. Time of onset and offset is increased in elderly and infusion more than 27 hours. The time of offset is prolonged. Should also do monitoring for BRIS. Second line choice of sedation, haloperidol. Haloperidol is a typically antipsychotic drug widely used to treatment of delirium with less sedation associated with hypotension, no delirium with it, of course, and no respiratory depression or deep sedation. Inhalational agent like sevoflurane or isoflurane. In COVID pandemic and shortage of facilities, many of centers started to use their anesthesia machines, ventilator, and also using inhalational agent, which is carry some risk like malignant hyperthermia risk and need its precaution and monitoring. It's rare but require urgent treatment. For inhalational agent, no accumulation in hepatic or renal patient, and rare cases of diabetes insipidus after prolonged use of sevoflurane at high dose. Ketamine, higher doses, more than 1 to 3 milligram per kilogram per hour, associated with hypotension, decreased cardiac output, is reported also with this high dose. Lorazepam is more potent than midazolam with longer duration of action, but it has higher effect on delirium. Phenobarbital also can be used as a sedative choice. Actually, using this technique of analgesia-based sedation or analgesia first, we can't see re-intubation in this case, but we are seeing many cases of self-extubation because of this technique, but it has its benefit also. We just will mention shortly analgesia and sedation in acute respiratory distress patient, ARDS. They require deep sedation and even neuromuscular blocking. The using of neuromuscular blocking is to optimize the mechanical ventilation. And before administering of neuromuscular blocking, patient should receive adequate analgesia and sedation to provide acceptable pain relief as well as amnesic effect. Analgesia first, analgesia-based sedation, of course. Use of analgesia before sedation for pain management or an analgesic with sedative properties is preferred. This approach has been developed to avoid or to decrease the use of sedation and to facilitate better ventilatory weaning. Shortly, we'll mention neuromuscular blocking, not in details, just we'll mention that we are using it in continuous infusion like cisatricurium, atricurium, glucurinium, are typically reserved for ARDS patients with severe refractory hypoxia despite ventilatory optimization, as we need more aggressive ventilatory technique. In case of shortage, as we see in this COVID pandemic, in this case of shortage of facilities or drugs, we can use intermittent bolus, not continuous, as needed, guided by ventilatory synchronized with the patient or the neuromuscular monitoring. Also, adding magnesium can potentiate the effect of neuromuscle blocking agent or using long-acting drugs like vicronium. In acute respiratory stress patient, deep sedation is required, so we can use midazolam infusion for this patient not adequately sedated with continuous opioid and propofol and Brezdex infusion. However, benzodiazepam associated with high risk of delirium and predict not to give adequate depth of sedation. For prone position patient, we see it too much in COVID patient or ARDS. The prone position is recommended when BO2 ratio to FiO2 ratio less than 150 with deep analgesia and sedation as well as the neuromuscular blocking agent. It improves gas exchange, improves respiratory compliance. It provides adequate or effective lung protection. Also, neuromuscular blocking can limit the related paratrauma, coughing, patient ventilator asynchronicity, or complication. Lastly, we'll talk about analgesia and sedation in COVID-19 patient. Analgesia and sedation in COVID pandemic has changed the approach of sedation. We was talking about not too much deep sedation, but in COVID, we are going toward the deep sedation and urgency of the use of benzodiazepine. This was driven by propofol and fentanyl shortage, as well as concern regarding lung injury seen with COVID, which need more aggressive ventilatory strategies that require deep sedation. Agitation and self-extubation also during prone position push us to go for deep sedation technique. Thank you very much. Hello?
Dr. Haytham, any problem?
No, I just finished the presentation. Thank you very much.
Okay. We cannot see your camera, Doctor. Afwan.
Okay. Clear now?
Yeah, not connecting. Yes, Doctor, شايفينك أهلا.
Okay.
We don't have any questions or answer. Any questions?
We will wait 1 second to see any
Yeah,
questions.
sure, Dr. Shaima, yeah.
No questions. I think it's clear. يعني, thank you, doctor.
Thank you.
It's very clear and informative lecture.
Okay, thank you. Thank you very much for all this nice work and organization.
Thank you. So now we'll go for our 10 minutes break.
Okay, thank you.
Thank you, everybody.
Hi, everyone. We will come back now. It's my honor to represent now my dear colleague, Dr. Fadi Gerges, cardiovascular imager and clinical cardiology specialist and critical care, Mediclinic Al Jawhara Hospital, UAE. Welcome, Dr. Fadi. Floor is yours. We are happy to hear from you lung ultrasound in COVID patient in ICU. Dr. Fadi, mute, unmute, screen. Presentation, I see it. Your cam and your voice, Dr. Fadi.
Hello, Dr. Shana.
Hello, doctor, welcome.
I will share from my side, Dr. Fadi.
Hi, can you hear me now? Okay, this is great.
Yes, doctor, we can hear you.
I'm not sure if my voice is okay or still unstable. Sorry, I think there's something okay now. Am I clear?
You're clear, but yes, now clear. Okay.
Can you give me 2 minutes, Dr. Shana? I think
topic.
I better change the connection, the Wi-Fi. Thank you, thank you. You can give me 2 minutes. I will change the Wi-Fi connection because I think the voice is interrupting. It's not pretty clear.
No problem.
Just give me 2 minutes.
Yes,
Okay.
yes, sure. It's an important topic, lung ultrasound in COVID-19 patient in ICU. It is a very important topic nowadays, according to the era of COVID-19. And it's a very important tool to use lung ultrasound in these patients as a safe life in the emergency rooms. If you have the transducer and make this ultrasound, it will be useful in diagnosis, and you can save life from this tool. I know that Dr. Fadi will give us more ideas how he can use this tool in this patient.
Dr. Shaima, do you want to go through the next stage just to review what lectures we have tomorrow, presentations?
Yes, okay.
No, for tomorrow, yeah.
Yeah, for tomorrow the schedule. Okay.
Tomorrow we're going to start at 2 p.m.
2 p.m. inshallah. I'll start with the neck veins clinical examination, and it's very important in our daily use in every patient. And I'll give also some videos how to insert Cvb, how to examination neck veins, and the clinical presentations. And after that, we will talk about hypotension in ICU. And Dr. Islam will give a topic on the new device and published paper about it. New device used in hypotension patient in ICU. After that, what is the program?
After that, we have the protocols and criteria for weaning from the mechanical ventilation. Dr. Fadi, Georges as well. And also an important topic, Dr. Shaima, during this time, it's infection control in ICU.
Dr. Miss Maha.
Yes, Ma'arij. And last topic for tomorrow, we'll end with that day 2 of this interesting workshop is by Dr. Vinayat. It's a point of care echocardio.
Yes.
So it's quite interesting topics, more practical, I feel.
Yes.
Tomorrow.
Dr. Fadi, welcome back. Okay.
Hi, I'm sorry for the technical issue.
No problem.
Okay now?
Okay.
Okay,
yes,
perfect.
loud and clear.
Okay, wonderful. That's better. Good evening, everyone. I'm very privileged actually to be here with you in that outstanding basic intensive care workshop. I'm sure that it will be quite successful and interesting. I will cut to the chase. I will not be very long in the lecture. I will just show more of actually like live videos and live cases of how we can do lung ultrasound in the ICU for COVID-19 patients. So basically, we will talk about how to do the lung ultrasound and how to hold the probe and how the learning curve of the lung ultrasound as well. So next slide. Can I control from here, Ahmed? Can I control the slides? Is it possible?
Yes, doctor, seems possible. Yes, you can control from your side.
I think I don't have a control for it. It looks.
We will open it. They will give you access.
Shared already, but okay. Thank you very much. I think it's not working, Ahmed. Only the flyer is coming out. Yeah, okay. Now it's fine, but I'm still cannot control the. Can I share it from my side? What do you think?
Dr. Fadi, can you manage to control or not yet?
Not yet, actually. It's not coming up in my screen here.
You can share
can I share
from your side?
Okay, great, perfect. So I can share it from here. I think it would be, yeah, okay. Now you can see it?
Yes, doctor, yes.
Okay, perfect. Yeah, I think now it's fine.
Just make it a slideshow, please. Yes.
Is it okay now?
Yeah.
Perfect. Okay, so there's like around 5 or 6 key points I will manage to discuss here during this lecture. First of all, the point of care lung ultrasound and how we can use it in those patients with severe COVID-19 disease, because usually it's associated with very worse prognosis eventually. Second point is how to diagnose the pulmonary complications on the lung ultrasound, starting from pulmonary edema, pneumonia, atelectasis, pulmonary infarctions. Why the lung ultrasound is more reliable than the plain chest X-ray, and it's almost now comparable to the CT chest regarding the pulmonary complications of the COVID. However, it's operator dependent. I will get through this. How is this really quite operator dependent? How to hold the ultrasound probe and perform the study, and what kind of probes shall we use for this purpose? We will go through the different chest zone protocols as well for the lung ultrasound imaging. And finally, we will demonstrate as well the real-life cases of COVID-19 patients with the lung involvement. Some of these patients actually made it and recovered, and others, unfortunately, did not. We'll first start with the point of care lung ultrasound and how is it an efficient tool to diagnose interstitial pneumonia associated with the coronavirus disease 19. So basically, there's a lot of advantages in the ultrasound, and you can tell that during the COVID pandemic, not much patients during that time when they were quite unstable for transfer to the CT radiology lab for a CT chest. It was very difficult due to instability, whatever they were in shock, septic shock, and also. So the lung ultrasound was a very good tool to demonstrate the pulmonary complications in those patients. It has a great potential as well in the early identification of pneumonia and acute congestive heart failure associated usually with COVID pneumonia. So why do we really use the lung ultrasound? We have plenty of points that we should show here during this brief lecture. First of all, you know that the plain chest X-ray is not reliable all the time. You can see a lot of shadows, a lot of artifacts. You cannot see the pleural effusion quite meticulously, and you cannot quantify the amount when you do a chest X-ray. Second, there is, even with an experience, differentiating sometimes between some conditions like pneumonia, pulmonary can be challenging, even by the lung ultrasound. So that's why I'm always explaining that we should correlate clinically with the patient's condition. The lung ultrasound is easy to learn. It's non-invasive, it's rapid, repeatable, and can be performed actually at the bedside. And sure, during the pandemic, we have to be careful that lung ultrasound, we have to be in the full PPE during the study, because otherwise it's quite infectious to be very close to the patient without managing to take care of ourselves first. The lung ultrasound is more sensitive and reliable than the mobile X-ray and the detection, especially of the pleural fluid, like we talked about it. And it can detect even as little as 100 ml, which you cannot really see, and it's almost impossible to see this small amount of pleural fluid on the X-ray, on the plain normal X-ray. The thing which is a bit challenging is that it's operator dependent eventually. So the thing that the learning curve is not really slow, it is fast. You need at least like from 1 to 2 months, which is not quite a long period to learn how to do the ultrasound. So you need to practice first on a lot of patients, even normal patients. So this is the chest zone protocols for the lung ultrasound imaging. And basically there are 2 protocols which are common worldwide, and it was quite common to the investigator in the studies, which one is better. to tell you the truth, the 8-zone method protocol is quite complicated as well, because somehow you get the cardiac shadow in the zone 6, for example, here in this zone, and you cannot see much in the zone 2 as well on the right line. So basically you should go, which is more simpler to do, is the 6-zone method. So anteriorly, which is on the right and the left side, and lateral and posterior and basal at the same time. So you go more axillary and you just go down till the border of the liver on the right side and the border of the spleen on the other side. So in this way, you can really quantify the pulmonary congestion and the heart failure, and even in the pneumonia, you can see consolidations, you can quantify the effusion. So this is basically the same picture that we had. It's just more closer, so you can really appreciate the zones. So to make it simple, like I said, I usually work on these 4 zones specifically. And this is the most findings you will find in these 4 zones of the left chest as well as on the right chest. However, in the thin patients, I can really tell you that it's very nice if you can do ultrasound from the back. Get the patient sit and then do the ultrasound from the back. You will quantify more precisely the amount of the effusion, the consolidations, especially if there is an effusion. The effusion usually is a very good clear media to see the lung tissue if there is a disease. So when the patient is thin and there is some effusion, you can see the lung tissue quite meticulously. So how to hold the probe of the ultrasound? The thing that, see, it's different things from an operator to another, but basically it should be very simple. You should hold the probe so that your hand rests comfortably on the patient's skin, like holding a pen exactly. Minimize a lot of movement for the probe. Otherwise, you will be confused with the movement of the pleura, because this is a key feature of the lung ultrasound to recognize the presence or absence of pleural movement. Last thing is resting your hand firmly on the patient's skin, which is quite vital. So this is actually, it's quite intriguing here, these 2 images. So yeah, you can tell that this is an illustration of how to hold the probe for the lung ultrasound. On the left side, you can see that this is actually the spot which is the best for picking up a small pneumothorax in the supine patient position. Number 2, on the right side, scanning around the back. Like I said in the previous photos, you have to go just quite axillary and posterior laterally, and then you go to the back curving. This spot is best for picking a small pleural effusion. So the lung ultrasound offers the diagnosis of the following: the pleural fluid and pleural diseases, pneumothorax, pulmonary edema, or cardiogenic pulmonary edema, and even non-cardiogenic pulmonary edema, like in ARDS, pneumonia, abscess, pulmonary contusions. Sometimes in massive pulmonary embolism, when you get a pulmonary infarction, you can really see through the lung ultrasound. You just have to do it right. So you don't really see a normal lung at all on the lung ultrasound. There is usually the pleural line, which is like a twinkling curtain sliding back and forth. And you can identify the pathology of the patient from that pleural line. I will show in the next slides how you can tell where the pleural line and which pathology is identified and how can you describe it exactly. So it should normally be sliding back and forth, like I'm saying, and it should be whitish and bright and glistening with no irregularities or cracks or fissures. So this is the normal pleural line for any patient. Then comes the A lines, which is basically bright horizontal lines. They call it the A lines, and it should be there in the normal lung. So this is the illustration regarding the lines in the lung ultrasound. Here that left image shows one repetition of the pleural line, which is here. This is what we call the A line. It's horizontal, whitish. This is the pleural line over there. The most thickest and bright line near the surface of the skin, that will be the pleural line. And the A lines mean that this is a normal lung. So On the other side, if you look at the right of the screen, you'll see the B lines, which I'm sure that a lot of you heard about it in both pneumonia or consolidations and COVID-19 patients, and even in cardiogenic pulmonary edema as well. So you can see that this is an ill-defined vertical comet tail artifacts. And by the way, the B lines are considered as artifacts. However, at the end, we call it artifacts. So this is the pleural line, this one over there, the glistening white horizontal line, and this is the B lines. So you cannot be confused here with the A line because the A lines is horizontal and there is no B lines here. Sometimes you can find a B line like this, 1 or 2 B lines, which are somehow like, you cannot confuse it with this lung rockets like they say. This is completely normal. So here you can see 5 B lines actually, and they arise from the pleural line. If you look, this is a pleural line, and the B lines arise from the pleural line as an artifact, creating a pattern of what we call it the lung rockets. They are vertical, long, well-defined artifacts, and usually they erase the A lines. You can see that there's no A lines here, the ones which we can see over here, because this is not a normal lung. However, that one on the left side is the normal lung. So usually it occurs also when there's sliding of the lung. So the normal thing that our pleura is sliding. So if you have, for example, a patient with a pneumothorax, you can never find these B lines because there will be no sliding of the pleura. So there is no B lines if the patient has pneumothorax. So first 5 simple questions you have to ask yourself when you do the exam or the lung ultrasound is there lung sliding or not? This is, I was just talking about it right now. The lung sliding will not be in pneumothorax, but it should be there in other lung conditions, even if there is effusion, pulmonary edema, ARDS, but it's only absent in pneumothorax because there is air trapped in the pleura. So there is no sliding of the lung in this case. Second question is there pleural fluid? And I will show you how to identify pleural fluid in the lung ultrasound. Are there A lines, which is the normal lung, or B lines, or there is no lines at all? Is there consolidation in the lung ultrasound? Is there pleural line irregular or regular? And you have to describe it. If it has cracks, fissures, irregularities. So this is what the first part of our lecture. Then we will go now to the real life cases of patients with COVID-19 with lung involvement. Some of them, they made it through and others passed away. These are real patients which I had them in my archive, and I will share it with you right now. So we'll start with case 1. Patient had a 65-year-old, he's obese with comorbid conditions, hypertension and diabetes. He had a witnessed cardiac arrest and was called in emergency because he collapsed. His blood pressure was not recordable. That patient, I've seen him 2 weeks back in the clinic and was pretty fine. He was just coming for a medicine refill. So during the, he suddenly arrested, like I said, and during the cardiac arrest, we found out that he had no ROSC. He was in asystole. And we thought of doing lung ultrasound during the CPR because actually that was during the first wave. There was a lot of cases of COVID and we were very cautious with every patient. So we thought to do a lung ultrasound. I did lung ultrasound for this patient during the team was doing CPR at that time. And you can see from here that this is a pleural line that we talked about, the horizontal line. It is quite irregular. It's not very obvious. This is not very nice images, by the way, because the scene was in a mess and people were doing CPR at that time and chest compression, ventilation. But I will show you how things go. You can see the B lines, which is the comet tails or the rocket tails. And on the other side, by the way, that patient, his PCR came positive, but this is later on after we took the PCR from the endotracheal tube after cardiorespiratory arrest. You can see on the right image, the clip, sorry, that there is consolidations. This thing actually is a bronchogram. This is the same air bronchogram that you see on a CT chest. So you can see it's very obvious in this patient. And we found out that the patient had COVID-19. His PCR was positive. He arrested at once. We couldn't revive him, but the lung ultrasound at least told us, what was there. He had a severe COVID pneumonia with consolidation. This is subpleural consolidation because it's just beneath the pleura and it's extending to some other areas of the lung. Another case where there was a 27-year-old Asian male. He had a mitral valve replacement. And he was seen 25 days back as well in the clinic. The patient came with acute dyspnea. He was shocked, collapsed. His saturation was 72%. He had a non-rebreather mask at that time. I was called actually to assess his mitral valve prosthesis just to rule out stuck valve or cardiogenic shock as a cause for his shock and hypoxia. So at that time, lung ultrasound was done. And we had a doubt. You can see on the right image, this is the echo, the 4-chamber echo. This is a mitral valve prosthesis. It's working pretty fine. His LV function, actually, it's not really bad. It doesn't explain what happened. However, this is a lung ultrasound for his left lung near the base on the posterior lateral part of the lung. You can see this is a pleural line. The pleural line is fissured from here. You can see that there's cracks, irregularities. It's not straight, it's not clean. There's B lines reflected from up till the end of the subpleural consolidations as well over here. And the pleural line is quite fissured and cut from over here. It's not straight like the normal patients. So that's the same patient, but another nicer views. You can see here, this is a pleural line I was talking about. The line should be straight and continuing till the end of the screen here. But you can see it's cracked, again, irregular. The B lines are reflected from the pleural line. There's subpleural consolidations. So we call it a dirty pleural line. This is the same patient as well. The B lines are more frequent here. So his PCR as well, it came positive. But eventually, that patient fully recovered. He didn't need mechanical ventilation, discharged after 12 days. He was admitted in the COVID ICU at that time. But surprisingly, there was no mechanical ventilation. He recovered very well at the end. So case 3, there was a middle-aged male patient. He's known to have already heart failure, but he came with acute decompensated heart failure with cardiogenic shock. It's a known case as well of valvular heart disease. He had a dilated cardiomyopathy with bicuspid aortic valve, severe aortic regurg, aortic stenosis, multivalvular involvement. There was severe LV dysfunction. His EF was around 20% with biventricular failure. Even the RV function was impaired with pulmonary hypertension. So at that time, the patient presented with hypoxia. He was in room air. Saturation was around 70%. And then we attached the oxygen. His blood pressure was low. Heart rate was 104 beats per minute. He had a wet lungs. There was no fever, no symptoms of viral infection so far. We did some investigations, full workup as usual. His Pro-BB, as you see, it's shooting more than 5,000. D-dimer was high. A normal white count. Procalcitonin was normal. CRP was normal. So there was no such markers of inflammation of infection. So even his LDH and ferritin and cultures were normal after we see it after 2 days after the results. So that was his echocardiogram. You can see that there was a severe LV and RV dysfunction. The RV is very poor, dilated both atria, severe mitral regurg, severe torrential tricuspid regurg as well. You can see there is mild pericardial effusion on the posterior wall and even on the lateral LV wall. So the thing that patient had the same echo findings like that 1 month back when he was following in the clinic. So that was not new for him, the echo findings. It was not something acute, but he had a decompensated heart failure. So we did X-ray. That was on admission on day 1, day 3, and day 5 during the admission. You can see that there are signs of pulmonary congestion all over the chest X-rays, and none of them actually was good. And there was not much improvement even after treatment. So that was his lung ultrasound. So look at this pleural line over here. This is not the same pleural line we have seen with the COVID-19 pneumonia patient. That's the typical glistening pleural line, which looks normal. It's bright, It's regular, no cracks, no fissures. B lines are all over the lungs, both lungs, right and left. We don't see much areas of consolidation or atelectasis or subpleural consolidations. So in fact, it was very typical of pulmonary edema. And we had after that a CT. So the CT was done after he improved a bit, but you can see some atelectatic bands on the CT. There was some consolidations, like here, some patchy consolidation. There was no typical pattern of the ground glass consolidations, some pleural effusion. Otherwise, the CT was not very much conclusive of COVID. So we were thinking with the team, was it really typical of COVID or not? And after that, the SARS-CoV-2 swab came positive and then repeated and came negative the week before it was already negative. So he received just the guideline-directed medical therapy of heart failure, dobutamine infusion. We maintained the negative fluid balance with diuretic, Entresto or sacubitril valsartan, and spironolactone. They already started him on hydrochloroquinolones and azithromycin and antivirals. However, then it was stopped by the intensivist after the findings of the lung ultrasound and the CT as well. So that was the patient, same patient on admission. You can see how the lung was quite awful, and there was a lot of congestion, interstitial lung edema. And this is 2 days only before discharge. It improved much, in fact. There was still remnants of congestion. However, it's much better than before. So that's another interesting patient. It was a COVID pneumonia patient. So these two images are very interesting, and we can tell here about these structures. It's very important during the lung ultrasound. You can see there was a massive pleural effusion on both the right and the left side of the patient. And this finger-like projections over here, this is the patient's lungs, in fact. There's a complete total lung loss, both here and there. So this picture, usually it's a compressive atelectasis when there is massive pleural effusion and the patient had pneumonia or consolidation. And you can see that the effusion will compress on the lung and will cause eventually atelectasis plus the infection. So here there was a total loss of the lung tissue with obvious consolidation. We can see here, this is all consolidation, by the way, due to the compressive atelectasis. The patient was mechanically ventilated, and you can see the free-flowing pleural effusion with extensive hypoechogenic areas. So that patient, in fact, after that, we did again lung, sorry, that was the previous patient. Yeah, this is the case 4. That patient improved, by the way, and he did well after that. However, we had to do a pleural tap. That was case 5. This is very interesting as well. You can see from the lung ultrasound that patient, in fact, had an ARDS and was on mechanical ventilation during this study. You can appreciate very much the cracked appearance and irregularity of the thickened pleural line with frequent B lines reflected from the pleural line. Pleural line is not a straight line. It's not regular. You can see the cracks here and the openings and the fissures as well here. So that was severe pneumonia with significant lung tissue damage. Case number 6, again, that was a patient with acute pulmonary edema. Same patient like we've seen before. This is just an illustration of the B lines. You can see how does it look like. And the pleural line, the clean pleural line as we call, it's devoid of crackles. So it denotes more for cardiogenic pulmonary edema. You can see it here clearly on the clip. This is a very significant, bright, normal pleural line, glistening with no cracks. So that means the patient doesn't have pneumonia. And this is B lines reflected. So you have to know also that the presence usually of more than 3 B lines per rep space suggests so much that there is a presence of interstitial pulmonary edema. That's another illustration for the lung ultrasound and pneumothorax. We have talked before about the sliding and the non-sliding of the lung and the pneumothorax, because this is the only condition where there is no lung sliding or pleural sliding. So this is a pneumothorax and a COVID-19. And likely you will see this kind of pneumothorax in those patients induced by the ventilation. And I'm sure our colleague will talk about the mechanical ventilation in details regarding those kind of patients who develop barotrauma due to the high pressure of the mechanical ventilation. So because we didn't see that there was a spontaneous pneumothorax that comes with just infection without the patient having. So this area, there is a pneumothorax. You can see that this kind of illustration, this we call it a stratosphere or a barcode sign, because actually there is no lung sliding here. That's why it appears this way. So, and they call it eventually a barcode sign. And this is a normal lung on the other hand. And this is all an M mode of the lung. Here we have a 2D of the lung, and here we have an M mode. You can appreciate from the M mode that there is no lung sliding here at all, and there's a stratosphere sign of the pneumothorax. However, this, we call it a seashore sign, which is usually with the normal lung and not a diseased one. Again, this is uniformly parallel horizontal lines above and below the pleural line. This is a pleural line, and this is horizontal lines. We call it, like you say, the barcode sign or stratosphere. It just looks like the barcode. It's very typical. And this denotes usually a pneumothorax. There is lack of motion of the chest wall or the lung, or absence of lung sliding, as we mentioned before, and that's why you can see this picture here. However, this is a normal lung with a seashore sign. So eventually, last but not least, this is a take-home message. During the pandemic, it's better to serve your patients and protect yourself first. So we sure serve our patients, but the thing that you cannot just go carelessly and do the lung ultrasound without proper protection of full PPE and according to the proper guidelines. So make sure that you are safe first, protect yourself, and then you can do the bedside studies like the POCUS or the point of care lung ultrasound. Use the masks, gloves, and other PPE with discipline. Wash the hands often, decontaminate surfaces, including stethoscope, cellular phones, all the devices, appliances, and devices frequently. So in patients suspected for COVID-19, the lung ultrasound patterns integrated with the patient characteristics now to rule in or to rule out COVID-19 pneumonia, it has a lot of high accuracy. And like I said, the learning curve is not really slow, it's very fast. So if you need to learn the lung ultrasound, which is a very good maneuver to do it bedside, and sometimes avoid doing a CT if the patient is not stable, because right now the lung ultrasound is quite comparable with accuracy to the CT chest as well. So this approach could support and expedited patients management during the pandemic surge. Thank you very much. I really appreciate your attention. Thank you.
Thank you, Dr. Fadi, for the illustrative and informative lecture. If there is any question.
Thank you very much.
MashaAllah, all are happy from the lecture, Dr. Fadi.
Yeah, thanks really, Dr. Fadi, for this very nice and interesting lecture.
Thank you. I really appreciate it.
Yeah, I think point of care.
I'm sorry for the technical.
No, that's fine. And I think point of care now in COVID is a very important tools for the diagnosis and for a quick management, as you mentioned in your lecture. Especially those patients who are unstable to shift for CT or for another diagnosis. So point of care ultrasound will be very helpful in the management of those patients.
Exactly, true.
Thank you.
I think there is a question, Dr. Fadi, in the question and answer box, Q&A. Is there a specific probe to use in lung ultrasound?
Yes, well, the thing that if the same cardiac probe that you use for the echo you can use for the lung ultrasound to see the deep structures, like for example, the pleural effusion. In fact, the pleural effusion, in order to visualize and estimate, is much more better to use the cardiac probe, much better than the linear or the curvilinear. However, if you need to see for example, some other superficial structure like the pneumothorax, you will not be able to see actually using the cardiac probe. You will need to go for the curvilinear probe. So the vascular probe can sometimes work, but still it will not show much like the curvilinear. So for the pleural effusion, for the consolidations, to see the pleural line, to see the B lines, you can still use the cardiac probe. And actually, most of the studies I've seen, in fact, like almost 90% of the live clips I have showed you now, it was using the cardiac probe, not the curvilinear. So you can see that you can see a lot of things clearly. You can see the B lines, the rocket tails, the pleural line. You can really estimate the amount of the pleural effusion. You can see the lung collapse and the pleura, how does it slide. You can see the diaphragm moving along with the effusion, everything in details. So I prefer the cardiac probe in most of the situation.
Okay, that's good. Another question, Dr. Fadi, what are the signs of COVID-19 on the lung ultrasound?
Well, in the early COVID-19, you will not find much. And usually it correlates very much with the CT. For example, a patient presented you with early signs of cough and some slight fever. You will not expect to see much on the lung ultrasound. Exactly like what happens when you do the X-ray chest. So the findings will be more prominent at that time after maybe 3 to 4 days of the infection and after the symptoms. So for example, the patient that I showed that already arrested and passed away, even though we did a lot of CPR and he didn't achieve ROSC, that patient was a bit of exception because he was a cardiac patient. He had almost like more than 24 hours of dyspnea that was not relieved. He's morbidly obese. So apparently he didn't, he was not so much careful about the symptoms, and he thought it's more like from the obesity or from the poor effort tolerance and all that. So he came by collapse and he arrested suddenly. And the thing that we can see that there's B lines, the pleura, you can see that it was already irregular, cracked. We've seen even subpleural consolidation at that time. So I believe that usually on the second day of the infection, and when the patient has symptoms like cough, dyspnea, or some shortness of breath, then at that time you will see a lot of findings. However, the pleural effusion usually is not very early. It's a bit of advanced sign. So you will see it after the patient had a full-blown picture of COVID-19 pneumonia.
Okay.
And, Dr. Fadi, how it is helpful, this one, for the follow-up, the prognosis of the COVID patient in the ICU?
Yes, we've done a lot actually, especially in the previous wave, which was like 7 to 8 months back. We had a lot of COVID patients and they were admitted in my hospital. So we used to do follow-up ultrasound, for example, on day 1 and then again on day 5, especially when we cannot do a follow-up CT. So we found a lot of changes. So, for example, the subpleural consolidations were more in a homogeneous pattern, and they were more scattered after 4 or 5 days from the infection. In the first day, we didn't see much of it. The B lines are more frequent, the B lines of the pneumonia, not of the pulmonary edema. The pleural line usually after 1 or 2 days start to be more, like I say, dirty and scattered and glistening and with irregular pattern fissures. Where you can really correlate it very much with the CT as well. So the pleural effusion as well, we can estimate it and do it every 2 or 3 days whenever it's increasing, because the chest X-ray, usually the portable one, I mean, especially in the ICU, is not really practical, and it's not very much accurate to see the pleural effusion and even the consolidation. You will just see a little bit of like heterogeneous patch. You can see all the things by the ultrasound much more meticulously, which you can correlate very well with the CT as well. And
one more question: do you recommend to use the POC ultrasound in the emergency? I mean, we can train the junior doctors and doctors also in emergency to use the ultrasound?
In fact, I started to do some kind of like a program to do this thing also, to learn the doctors in the hospital, especially the urgent care or emergency doctors, how to use it, because like I said, the learning curve is very fast. It's not slow. And if you decide to learn how to do point of care ultrasound, it will take like maybe 30 days to 45 days, and you will be quite professional, especially when you see more number of cases. So I believe that this is a very important point, that we should pass the notion and the teaching to the urgent care doctors. Exactly.
Thank you, thank you. I think from your answer, I just put in that, yes, we need, I think, to develop a program for the VOC ultrasound, especially in the emergency department. This would be very helpful for the diagnosis.
True.
Thank you,
Dr. Fadi.
I appreciate that.
Thanks a lot. Thank you, dear.
I enjoyed with your lecture. Really, it's very clear for all, and it's very important in this era. Thanks so much for your effort and for your time.
I really appreciate it. Thank you very much. Thank you.
Now we will introduce our colleague, Dr. Khadija Hamid, septic shock management. Dr. Khadija Hamid, Chief Resident, Anesthesia and ICU, PDF Hospital, Bahrain. Welcome, Doctor. The floor is yours. You can share your screen, Doctor, and unmute yourself. Yes, okay. Share screen. Yes.
Assalamu alaikum. Thank you so much for giving me this great opportunity to be part of this wonderful team and this very informative and hopefully, inshallah, everyone will get the most out of this event, and we'll look forward to make it more and more in the future. So my name is Khadija Hamid. I'm from BDF Hospital. Inshallah, in the next half an hour, we'll be talking about septic shock. We'll go quickly through a quick introduction. We'll just review for the interns and the students, the types of shock, definition of shock, and then we'll go into sepsis definition according to the latest guidelines, the pathophysiology, and then we'll review the Surviving Sepsis Campaign guidelines in the treatment and management. Okay. So why is septic shock important? It's very, very common. You're going to face it everywhere, starting from the ER, in the wards, and of course in the ICU, where the majority of patients there are septic shock. It has been increasing in the last 80 years, and it's the commonest cause of death, not only in the US, but worldwide. The mortality can reach up to 70% with an average of 50%. So that's why we always try to make like campaigns and involve most of the people, not only the doctors, to make them aware about the importance of sepsis and how to pick up septic patients earlier to prevent this mortality. Okay, so we'll start with shock. What does shock mean? Okay, so shock is basically a profound and widespread reduction in the effective delivery of oxygen and other nutrients to the tissues, which leads first to reversible, and then if it's prolonged and left untreated, it will lead, of course, to irreversible cellular death. And this is what we don't want to happen. Okay. And the basic concept of the oxygen delivery, or how to maintain good oxygen delivery to the tissues, is to maintain the oxygen balance. So usually our body has a normal balance between our oxygen that we are consuming and the oxygen which is getting delivered. Okay, so if for example, we have a high oxygen consumption, such as in any case with a high metabolism in the body. So for example, fever, thyrotoxicosis, seizures, all of this will increase your metabolism, which will increase your oxygen requirements. So if the oxygen delivery maintains the same, it will not be able to deliver the oxygen to the tissues. They need more. So you have to increase your oxygen delivery in this case, okay? The other important concept is, okay, now we want to increase oxygen delivery. How do we do that? What are the determinants of oxygen delivery? Okay, so we have three main things. First of all, the oxygen that you are getting, okay? So either through the face mask, if needed face mask or intubation, then this oxygen is normally carried by the blood, okay? So you need to maintain a good oxygen content by making sure that the patient has adequate hemoglobin level, okay? And then the third thing is the cardiac output. So the heart has to pump all of this blood, which contains the oxygen, to the tissues. And then the blood pressure also has to be maintained, of course, because if you have a good vasomotor tone, that will also maintain the delivery to of the oxygen to the tissues. Okay, so we look at each point and we try to treat that. So first, for example, the blood pressure, we give fluids first of all, and then if there is no response, we have to start vasopressors. For the cardiac output, if we suspect that there is a low cardiac output in this situation, then we have to consider inotropes. For the oxygen content, either you have to increase the oxygen by giving more FiO2, or increasing the hemoglobin by giving packed RBCs if needed. And as we all know, in normal patients, the hemoglobin, the ideal target of hemoglobin should be around 7. Whereas in acute MI or active GI bleed, or active bleeding overall, you have to maintain the hemoglobin around 10. Okay. So these are the overall types of shock, which I think you all know. But I just want to focus on the distributive shock, because most of the time when I ask mainly the interns and the residents, what are the types of shock? They say cardiogenic, hypovolemic, septic, and obstructive, okay? So septic is not a main type of shock per se. Septic is a part of a distributive shock. So what we mean by distributive shock is that the body has profound, widespread vasodilatation, okay? So this happens in sepsis, okay? But it also happens in other situations, such as adrenal crisis, where the cortisone, it usually maintains the vasomotor tone, okay? So if the cortisone decrease, that will cause vasodilatation. If you have neurogenic shock, that will also cause vasodilatation, because there is no more control by the central, by the higher centers. Okay, so they will have vasodilatation, but they will also have bradycardia. So that's a common feature to differentiate between the other types of distributive shock. And then we also have anaphylactic shock. An anaphylactic shock, they have widespread vasodilatation. And also keep in mind drug-induced, or for example, if you give the patient spinal or regional anesthesia, epidural, they can also have a sudden vasodilatation. All of these causes are under the category of distributive shock. Okay, so I just want you to keep that in mind. So how do we differentiate between the types of shock? We look at 4 main things. We look at the cardiac output by an echo. Okay, we look at the filling pressures also by an echo, or if you have a Swan Ganz or a pico monitor. Okay, and you look at the vascular resistance, which is the SVR, systemic vascular resistance, and the mixed venous oxygen, which we will explain more in the next slide. So in cardiogenic shock, basically the heart is not pumping, so definitely the cardiac output will be low. The filling pressures will be high because nothing is getting pumped outside the heart, so all the volume and the pressure is accumulating inside the heart. The vascular resistance will increase as a compensatory mechanism. They're trying to maintain the blood pressure, okay? So the SVR will increase, and the mixed venous oxygen saturation will decrease, okay? In hypovolemic shock, you have low cardiac output because there's no volume, there's no blood in the tank, okay? The filling pressures will also be low because of the same reason. The vascular resistance will be high as a compensatory mechanism, and the mixed venous oxygen will be low. Distributive shock, you're gonna have vasodilatation. The cardiac output will be normal or high at the beginning as a compensation to this vasodilatation. The filling pressures will be low or normal. The vascular resistance will be low, as we said, and the mixed venous saturation will be high. And the obstructive shock, there's obstruction. So the afterload will increase, the SVR is increasing, and that will affect the cardiac output. So the cardiac output will be low, the filling pressures will be high because there's an obstruction, and the vascular resistance will be high as because of the obstruction. So just a quick diagram, this shows you what is the concept behind the mixed venous saturation. Okay, so when we measure the mixed venous saturation, usually it's through a central venous line. Okay, we take a venous sample from the CVP, and we check the saturation from that venous sample. Okay, so what is the concept behind that? Now, normally the oxygen which we get inside our lungs, okay, it goes to the heart, and the heart pumps it to the tissues. It's of course being carried by the RBCs. The tissues, when it reaches the tissues, it will extract around 25% from this oxygen. They don't need more than that in normal circumstances. Okay, so let's say that the tissues got 100% of oxygen. So what goes back to the heart, what will go back to the right atrium, will be around 75%. So the normal mixed venous saturation here is 75%. Now, when we have a problem with the tissues cannot extract the oxygen, okay, because of mitochondrial dysfunction. This is what happens in sepsis. So it will be on the opposite. It will, instead of extracting 25%, it will be only able to extract, let's say, 5 or 10%. So what will return back actually will be higher. So a higher mixed venous saturation doesn't mean that it's better. It means that there is something wrong with the cells. They cannot metabolize. They are in hunger. They need the oxygen, but they cannot metabolize it. They cannot use it. So that's what happens in sepsis. And the other causes of shock that we have seen in the previous slide, all of them will be low because the tissues are deprived of oxygen and they're actually extracting more and more. They want more. So what goes back will be low. So you will get a low mixed venous oxygen saturation in this situation. Okay, so in sepsis, as we said, the patients will be hypertensive. They will have a normal or high cardiac output. They will have vascular dysfunction because of all the release of the cytokines, which we'll explain later. Okay, and they can also develop myocardial dysfunction, which we'll also talk about. So this is the pathophysiology. What happens normally when an organism reaches the body will try to defend himself. So it will release all what is necessary to overcome this organism or this infection. Okay, so starting from the neutrophils, the endothelial cells, they will release a lot of mediators. Okay, you don't have to memorize them all, but just to be familiar with. Okay, so we have like prostaglandin, we have oxygen radicals, prostacyclin, thromboxane, and endothelin. Okay, and that the endothelial cells the endothelial or the blood vessels itself will get damaged. Okay, so when it gets damaged, it will be more leaky, and the fluid will go out of the plasma will go out of the blood vessels, and that will cause edema. And that's why most of these patients have ARDS, which is non-cardiogenic pulmonary edema. Okay. The other thing also, which is very common, is the cytokine release, and this causes a cytokine storm. So what we mean by cytokines is the tumor necrosis factor. More common now in most of the hospitals or the ICUs, they measure the interleukin-6 level in septic patients. So this gives you an idea of how sick or how septic this patient is. Okay, and then we have also the fetal activating factor, the nitric oxide. Nitric oxide causes severe vasodilatation. Okay, and a lot of coagulation factors gets released. So the patients become hypercoagulable, but then later on, these coagulation factors get consumed. So they go into something called septic coagulopathy and DIC. Okay, all of this in the end will cause cellular dysfunction and cell death and apoptosis, and that will cause multi-organ failure. So their organs will fail one by one. So starting from the heart, they will get something called septic cardiomyopathy. Usually this happens in the first 24 to 48 hours. So usually when patients come to us hypertensive, we start them on vasopressors, and then we see that they require a very high amount of vasopressors. Then we have to check the heart. At this stage, we have to suspect septic cardiomyopathy, and then we start them on inotropes. Okay, and they also so they go into multi-organ failure. We said the heart, the kidneys get affected, the liver, they go into something called shock liver. Okay, and then if this is all left untreated, they will of course develop refractory hypotension, and they can die. So moving on to the definition of sepsis. Now, this was the old definition of sepsis. We used to have something called the SIRS criteria, which I think all of us know. So we have the temperature, either hyper or hypothermia, respiratory rate, tachypnea, tachycardia, leukocytosis or leukopenia, and low CO2. And then we consider this patient having sepsis if they have 2 of these SIRS criteria plus a confirmed or suspected infection. And then we used to say this patient has severe sepsis if they have a sign of end organ damage or refractory hypotension or lactate more than 4. And then septic shock when they have end organ damage and they're not responding to fluid and they need vasopressors, okay? But later on, they found that these, some of these criteria were not very accurate. Like, for example, the SIRS criteria, they found, like, for example, you can find a patient with leukemia who have a new onset AFib. So they can have these criteria, but they're not septic, okay? So that's why the latest SIRS or the sepsis definition, which is published in 2016, they eliminated the SIRS and the severe sepsis. So now we only have sepsis, which is life-threatening organ dysfunction caused by dysregulated host response to infection. And we have the septic shock, which is sepsis with underlying cellular metabolic abnormalities and hemodynamic instability requiring vasopressors with increased mortality. Now, the other thing that can help us predict the prognosis or the mortality of the patient is something called the SOFA score. So SOFA stands for Sequential Organ Failure Assessment. And what they did basically is that they looked at each organ and they chose a marker which tells you how much this organ is affected, okay? So, for example, the lungs, they looked at the PF ratio, which is the PO2 divided by the FiO2 ratio. Normally, our PF ratio is something above 600. But when it reaches 500 or 400, it's considered abnormal. So they give a mark for each number, okay? And the higher the score, of course, the higher the mortality. So you have coagulation, they looked at the platelets. If they have worsened thrombocytopenia, that's also a bad sign. The liver, they looked at the bilirubin, cardiovascular, the mean arterial pressure. If the patient is requiring inotropes, how much? Is it single or double? CNS, they looked at the GCS score, and the renal, they looked at creatinine and the urine output. So any sudden increase in the SOFA of more than 2 points will give you an idea that this patient's mortality is increasing by 10%, and that's why you have to keep an eye on them, okay? Now, the problem with this SOFA score, it's very detailed and it needs labs, and you have to wait for the results. So as we said, the time is very important here. So sometimes we cannot wait. So they came out with something called the quick SOFA score. So it's mainly for patients who are in the ward or in ER, okay, who it can be used by the nurse, and they can pick up these patients quickly and determine or alert the physician or the ICU quickly, okay? So the quick SOFA score, it's 3 variables: the respiratory rate, the mental status, and the systolic blood pressure. So any increase in respiratory rate above 20, systolic less than 90, and any change in the GCS, so any drop even by 1 below normal, it's considered abnormal. So if you have 2 of these 3 criteria, it will give you an idea this patient could be septic, but it's not confirmatory, okay? But you need to keep an eye on them. So example, keep them in a monitored bed and get all the labs done and wait for these labs till it comes out, okay? So if the quick SOFA, if you have more than 2 variables, assess for organ dysfunction. So by doing all of these labs, as we said, for the SOFA score, and monitor for clinical the condition deterioration. If there is suspected sepsis or there is signs of sepsis, then you have to go with the management, as we will explain later. Also, you have to keep in mind that there are patients who are at higher risk to deteriorate quicker, okay? So the patients with these risk factors have to be monitored closely. So for example, extremes of age, either children or elderly because of their immunosuppressed state. Any patient with impaired immune system, so chemotherapy, uncontrolled diabetes, sickle cell disease, patients on steroids, patients who had a recent surgery, patients who have indwelling lines, so for example, a PICC line or a permacath or a dialysis catheter, pregnant patients also, or who have had an abortion recently. These are all considered high risk. You have to keep a close eye on them. So moving on to the management. Now, the pioneer in management, or who came up with a protocol so we can all stick to the same page, is Emmanuel Rivers. If it wasn't for him, I think we would have been still lost and everyone was doing his own management or technique. So he came up with a protocol or like a concept to keep in mind and try to follow it, okay? So first of all, as we said, he was keeping in mind if you remember the first slide, the oxygen delivery and how to maintain the oxygen delivery. So he was following this. So first of all, oxygen, maintain oxygen, good oxygenation to the patient. If he needs intubation, intubate them. And then put the central line, arterial line, central line mainly for vasopressors, and arterial line to take frequent ABGs. And then consider sedation or paralysis if the patient is intubated, for example, or if needed. And then you have certain goals. So your first goal is the CVP. The central venous pressure should be not less than 8. Okay, so if it's less than 8, then you have to give crystalloids first. If there is no response, then you give colloids. And then the other target is the MAP, the mean arterial pressure. Okay, so if the mean arterial pressure is less than 65, you have to consider starting vasopressors as soon as possible. And then your other goal is the mixed venous saturation, which we discussed. If it's less than 70%, consider giving blood if the HB is less than 7 or 10, or even consider using inotropes, okay? And always, whenever you do any intervention, always reassess. See if the patient is responding to it or not, or you need to escalate your therapy. After that, the Surviving Sepsis campaign came out with this guideline. They always update their guidelines every 4 years. So this was the latest. And one of the very important concepts, if you're gonna just take this take-home message for septic shock, the management is 2 basic things, early antibiotics and fluid. These are the 2 things that you have to focus on in septic shocks, okay? So for antibiotics, they noticed that any delay in administering antibiotics for these patients, each hour delay will increase the mortality by around 8%. So you have to make sure that you not only ordered the antibiotic, you have to make sure that the nurse actually got it from the pharmacy and gave it to the patient, because it's very common, we always see it till now, that the patient didn't get the antibiotic, even in ICU, until after 3 or 4 hours, okay? So that's very, very important. The other thing, as we said, is the fluid therapy. These patients are dehydrated, okay, because of the severe vasodilatation. So usually what we do is we give them a fluid challenge, okay? And it's usually by around 500 to 1 liter crystalloid over 30 minutes to 1 hour. And then you reassess, and we'll talk about fluid responsiveness tomorrow, inshallah. And if the patient is, for example, at high risk of developing overload, if he's heart failure or renal failure, then you can try to avoid crystalloid and use a smaller amount of colloid, because as you all know that the oncotic pressure for the colloids is higher than the crystalloid, so most of it will remain in the blood vessels for a longer time. So moving on to the vasopressors. So which vasopressor will you start for the septic patients? Now, they did a lot of studies and they compared all the vasopressors, and they found out that the norepinephrine is the gold standard, or the drug of choice in septic shock patients. The problem with the dopamine, they used to prefer dopamine, especially in ER or in the ward. They used to start them on dopamine because you can use it to a peripheral cannula. It doesn't cause problems with norepinephrine like ischemia, because norepinephrine is a very potent drug, so you cannot use it within a peripheral cannula. But they found that dopamine was not that effective Actually, it had more side effects, like, for example, arrhythmias. So it's better to start norepinephrine as soon as possible. They even now recommend that even if you don't have a central line and you have a good 16 or 18 gauge in the antecubital fossa, you can start norepinephrine until you secure a central line. So what if the patient is still hypotensive with maximum norepinephrine? What is your other drug of choice? It's debatable. It depends on your preference, and it depends on the patient's condition. Okay, so for example, vasopressin is a good choice. Vasopressin is a hormone secreted by the body, and usually in septic patients, they are decreased. So they notice that when you give vasopressin in a small dose, you can actually decrease your requirements for inotropes. But we try to avoid that, and we try to avoid giving a high dose of vasopressin in patients who are at risk of developing like a bowel perforation or bowel ischemia, because it is very, very potent. Okay. The other drug is dobutamine. Dobutamine is actually an inotrope. So as we said, that these patients can also have septic cardiomyopathy. So if you did an echo or you have any suspicion of cardiomyopathy or low cardiac output, then you should start inotrope, and most preferably we choose dobutamine or milrinone in this case. Also, the other drug of the choice, epinephrine, but epinephrine also has lots of complications or side effects. It's a very potent drug. It causes very potent vasoconstriction, and it causes tachycardia, so you have to be cautious with it. And the last drug is the phenylephrine. Phenylephrine is a potent alpha-1 vasoconstrictor. It causes reflex bradycardia. So the only case which we use it in patients who have arrhythmias, which we cannot control. We can use it, but not to limit the dose and the duration as much as you can. Okay. Regarding our goal in the MAP, the mean arterial blood pressure should be 65. You don't need a higher MAP than that. They did compare a higher MAP, and they didn't find any increase in survival. On the contrary, they found more side effects because you're using a very high dose of vasopressor, so you have more side effects. Now regarding steroids, septic patients do have adrenal insufficiency, and the Surviving Sepsis Campaign guideline did recommend that you have to consider using steroid if the patient is really sick. He's hypotensive on very high dose of inotrope vasopressors like 2. So you should consider giving these patients hydrocortisone, 200 to 300 milligrams per day for 7 days. And very important, of course, is the source control. So always look for the cause, look for the source. If you don't eliminate the source, whatever you're doing is useless, okay? So according to the history, according to your examination, if the patient needs CT abdomen to rule out any focus or source in the abdomen, make sure there are no indwelling lines or catheters, which could be the source of infection, and that has to be removed as soon as possible. So they used to say source control is very important and it has to be done in the first 12 hours, but now they even say that it has to be done even in the first 6 hours. You shouldn't wait more than that. And of course, your endpoints, like clinically, how do you know if the patient is responding or improving or not? By examination, doing the capillary refill test, checking the extremities. Septic patients, usually they are warm because they are vasodilated, okay? But then later on, they can become cold. And that means that the patient is really vasoconstricted, and that means that you have to escalate your therapy. Looking at the urine output, maintaining it around half ml per kilo per hour. The mental state, if the patient starts to become confused or delirious, that means that he is hypoperfused. And always check the lactate level. Okay, so decreasing lactate is a good sign in most of the case, and mixed venous saturation, as we said. So they gave you a target, things to be done in the first 3 hours and things to be done within 6 hours. So in the first 3 hours, you have to make sure that you gave fluid, that you took cultures before starting antibiotics. If there's any delay in the blood culture, do not delay antibiotics. And you have to measure the lactate level, okay? And then check the lactate every 6 hours. And then after that, and the other, within the 6 hours, make sure that the patient is on vasopressors if he's still not maintaining a MAP of more than 65, and recheck the lactate level. Sorry. So this is our sepsis code that we use in the BDF. We started to implement it in the last 3 years, and it's available in the ER and the ward. So what we do basically, the nurse has this paper, and she looks at the patient if there are any symptoms of infection, such as fever, cough, chills, and 2 of the following quick SOFA criteria, which we have mentioned. So hypotension, altered mental status, or tachypnea. If that is present, then she has to activate the code sepsis, okay? So she starts with the bundle, the sepsis bundle. So within the 5 minutes, she obtains the patient weight, notifies the attending team leader, initiates a large bore IV cannula, and start to give oxygen to maintain saturation more than 92. After that, she has to take labs, including lactate, PCT, CBC, UNE, creatinine, LFT, and ABG, and blood culture. And then within the first hour, she has to make sure that the IV antibiotics is started. And if the systolic blood pressure is less than 90 or lactate is more than 4, then you have to start fluid 30 ml per kilo. And they mentioned that you have to calculate it per 30 per weight. And then check the lactate every 4 hours and start norepinephrine if the patient is still hypotensive. So the sepsis team, nurse for drug administration, nurse for blood collection, and the charge nurse and respiratory therapist if needed. So just a quick recap. We'll just take the scenario. So you have a 25-year-old male with productive cough, history of productive cough, tachycardic with a heart rate of 129, BP was 112/68, the respiratory rate was 27, and temperature was 38.8. So what other clinical signs and lab findings would suggest the presence of shock in this scenario? So as we know, the clinical signs of shock, starting from head to toe. So first of all, CNS, the patient can become anxious, confused. Later on, they become drowsy and it can reach a stage of coma. Cardiovascular, they have tachycardia and vasoconstriction, hypotension. Hypotension is a late sign, actually, we shouldn't wait for that. They can have tachypnea. Tachypnea is actually a very early sign of any critical state, not only in sepsis. So whenever you see a patient tachypnic, this is an alert for something, there's something going on, okay? And that's why it's also mentioned in the quick SOFA. Then moving on to the kidneys, decreased urine output, decreased bowel movement, pale, cool skin, and decreased blood supply to the muscles. Investigations, CBC, blood culture, D-dimer coagulation, blood type and cross-match, chemistry, ABG, lactate, okay, and of course, culture and X-ray and CT if needed. So this patient, as we said, his saturation, these were his same vitals, there were no change. His saturation was 90% on non-rebreather. His skin was warm and dry, and his lactate was 4.2 with a WBC count of 22. So what type of shock does this patient likely have? Because his skin is warm and dry, okay, this patient most probably has septic shock, and because of the other symptoms and signs that we already mentioned, okay? So what are the interventions? The interventions which will decrease the oxygen consumption. So as we said, anything which increases the oxygen consumption will impair your oxygen supply, okay? So you have to decrease the oxygen consumption. So in this case, the patient is febrile, so his oxygen consumption will be increased. So you have to decrease the fever as much as you can, okay? And interventions increasing the oxygen delivery, as we said, the oxygen content mainly is dependent upon the blood pressure, the cardiac output, and the HB, okay, and the oxygen. So increasing these things will improve the oxygen delivery. Regarding the fluid, which fluid would you give to this patient, okay? as per the Surviving Symptoms Campaign guidelines, usually we start with crystalloids. There were lots of studies comparing crystalloids to colloids. They all recommend that you have to start with crystalloids. Ringer lactate is more preferable than normal saline because normal saline will cause metabolic acidosis or hypercaloric metabolic acidosis if you give it in large amount. And then if you think the patient can get overloaded, like a renal failure or heart failure, you should consider giving colloids such as gelofantine, for example. Okay, so now the patient is satting 90% and he's on 80% oxygen non-rebreather. He was given 4 liters of normal saline and still his MAP is not maintained. It's 60 and his heart rate is 120. So what is the next intervention for this patient? And they started also norepi 0.3 mic per kilo per minute. So for any patient with hemodynamic instability, we should intubate the patient or secure the airway as soon as possible as an elective intubation to decrease the oxygen consumption, because usually these patients will be very tachypnic, they're very anxious. So all the oxygen is going to the intercostal muscles instead of going to the vital organs. So we prefer to rest the lungs and redirect the blood to the more vital organs, okay, till the situation is under control. And I think that's it. This is my main source of the lecture. This is Joseph Carallo. It's a very nice, informative lecture. And thank you so much.
Great, doctor. Thank you for your effort and your time. Thank you so much. Any questions?
Yes, we have one question, doctor. Somebody's asking, yeah. SOFA score, can it be applied to the neonatal period?
The neonates, I think they have a modified one. There is one for the neonates, but it's modified. I'm not really familiar with the neonatal one because I'm not working in neonatal ICU. But I'm sure they have a modified one for, they do use it for the neonates, yes.
Yeah, most of the entities like your presentation. It was clear to them. Dr. Muhammad, you want to conclude? First day, it was really active and interesting day with all these specialized presentations.
Yeah, really. Today we are getting on very interesting topics in the intensive care. And even we are saying this is an basic intensive care, but actually all our eminent professional speakers, they give us the required things on the intensive care and how we can improve our skills to provide the best care for all patients. The last lecture is also amazing regarding the septic shock, and I think it's very important, and we are all seeing so many patients in infection, and some of them are referred to the ICU to complete their treatment. And sure, we've done excellent team in ICU. Most of those patients are recover and get best care in the ICU.
I don't know. There is a question for Dr. Khadija. Do you want me to read it for you?
Yeah.
Is there any role of continuous infusion of antibiotics in case of sepsis? From Heaven.
Actually, there were some studies where they looked at, like, for example, tazocin, where we give it, like, instead of giving it over 1 hour, we use a prolonged infusion, like, for example, 3 to 4 hours. It is recommended. There have been positive studies for that, but I don't think it's for all the antibiotics. Like they have certain antibiotics which we use as a prolonged infusion. Yes, because it will stay longer in the body.
Thank you, Dr. Muhammad.
Yeah, today we have also a lot of medical students also are joining us. And I think with this workshop, they get some of knowledge about the intensive care unit and how the team are working and what are the important things they are facing during the care of the critically ill patient. Maybe during the medical student, they are spending more times in the ward and the outpatient. But in the intensive care, because of the limitation of the medical student to enter and because of the situation of the intensive care unit. And I think such a workshop will be a good opportunity for them to learn a lot about the intensive care unit and how they are managing the patient from the ventilator, Cvb, and all the important topics our speakers are presented today. I think tomorrow we will continue with a very interesting topic. Dr. Shema will continue about the central venous pressure, hypotension, and the protocol for and the criteria for the winning of mechanical ventilation. I will introduce one of the important things about the infection control in ICU, which is very, very important. And again, today Dr. Fadi gave us the point of care regarding the ultrasound, and tomorrow point of care for echocardiology. So I think with all these things, we hope be covering part of the things regarding the intensive care.
Sorry to interrupt, Dr. Muhammad. Dr. Khadija, would you? There are some questions for you in the Q&A box.
Regarding the blood culture.
By writing, or you want to answer now?
If you found the patient took antibiotics before the blood culture, shall we do a blood culture or postpone it? Actually, we still take a blood culture, even if patient took antibiotics. We still take a blood culture. It's still recommended. It still can give you an idea because sometimes the antibiotics takes time to work. So it will still give you an idea if there are any organisms, which type of organisms, is it sensitive to the antibiotic that you have already chosen or not. So it is better to do it, but just don't postpone it. Yani don't wait for the culture to be taken and then give the antibiotic.
And the role of inhalational heparin in intubated patients.
Inhalational heparin?
Yeah.
Is that for COVID patients or for septic shock? Because septic shock, I don't think there is any role. I don't know.
Yeah, the answer is
I'm not sure.
Yes, not clear. Yeah.
But for septic patients, no, there are no studies about inhaled heparin.
Another question?
Yeah.
One question.
What is the role of Spanish?
نفسه هو سأل عن الكلتشر. نفسه جاوبته.
Yeah, it's the same question. Okay, thank you all our speakers, and we're looking to welcome you tomorrow. Tomorrow we will start in the same time at 2 p.m. Bahrain time, and please prepare yourself for tomorrow.
Thank you.
Thank you, everybody.
Thank you. Thank you.
Thank you.
Thank you. Thank you.
Bye bye.
Thank you.